My name's Steve Palmer. I'm a professor in the Department of Health Sciences, and thank you for coming today. Welcome. This is our second. This is our second conference put on in this season, and this is put on by the Center for Health Equity Research, as well as the Arizona, funded and supported by the Arizona Biomedical Research Center. And this is our second conference for the year. These conferences are offered through NAU's CHER as well as the ABRC. And I'd like to say a thank you to John Garcia and the ABRC. John's online with us today, so thank you, John, for supporting these workshops. Also, a quick thanks to Aaron and our tech crew and Nick Beckett. Nick has, of course, coordinated all the details for this conference, as well as the rest of our conferences. He does an amazing job. So thank you, Nick. All right, so in February, we kicked off our programming for the year with a look at burnout in healthcare. We were in Phoenix, and Dr. Bernadine Melnick from The Ohio State University keynoted that conference. After today, we're looking forward on April 27th. We've got NAU's Dr. Janie Ingram and Dr. Michael Charles from Cornell, along with Hassan Lin and also Nikki Kosh from ADHS. They're going to keynote a conference on the healthcare response to water scarcity and quality. We're looking forward to that one. Then May 13th and 14th, we return to Yuma for our 6th annual conference on border health. This year, we're featuring research from Arizona and Mexican university scholars looking at regional resources and research around border health. So that's in May. And then our final conference for this year will be on June 6th. And that's coordinated by Drs. Don Clifford, Megan Meyer, and Natalie Pepini from NAU's Health Sciences. And they're bringing in many nationally recognized speakers for a conference looking beyond BMI and unraveling the complexities of weight, stigma, and care. So we hope if those are of interest, you're able to join us for those conferences as well. But today, we're proud to offer this conference on interventions and for substance use disorders, crisis management, and treatment resources. So thank you all for coming. It's my pleasure and honor to introduce Drs. Julie Baldwin and Ramona Malat, who have really, they're the brains behind this and bringing in these tremendous speakers and panelists for the rest of this conference. So I'm going to be done speaking and bring up these wonderful folks. They do an amazing job. They're so busy really diving into this, as well as many other challenging health topics. So thank you all.
Thank you so much, Steve. We really appreciate the opportunity to co-host this event tonight. As Steve said, this is part of the ABRC workshop series, educational series that we have through our Center for Health Equity Research at NAU. I'm the executive director of that center and also now involved as the vice president for NAU Health here. And Ramona and I have had a great opportunity of working together for now several years with a particular project that's funded by the National Institute on Drug Abuse, and it's called the Culturally Centered Addictions Research Training Program. And I just want to see are there any scholars out here today from a few from our program? Yay! So we've had this grant for now 3 years. And the main goal of the grant is to train predoctoral or doctoral students in addictions research. And so we're working with different departments. I might also mention we have many faculty from this group. So all the faculty, please raise your hands as well. Yay. So each year we have about 10 scholars that participate in the program. We're now in our 3rd cohort, and we are getting ready to have our conference in the next couple of days as well, which I think Ramona is going to tell you a little bit more about. But this program is specifically designed, again, to support doctoral students in clinical counseling, psych, school psych, other areas of psychology, as well as interdisciplinary health, occupational therapy, physical therapy, and we're hoping to even bring in some other areas too, like nursing and other areas like that. So, and what's that? Oh, and population statistics, yeah. But would you like to say, let's have Ramona say a few words too.
So just a quick word about the CCAT. Our conference is tomorrow. If anyone's interested, let us know. Shannon back there can help you get registered for it. And something else, we do encourage community partners. If somebody is really interested in getting the certificate, it's a very flexible certificate. Talk to one of us and we will get you the information. We're doing admissions soon after the conference is over. That's where we start to get ready for our 4th cohort. And all expenses paid, meaning we pay your tuition and books and all that good stuff. So.
Okay, so without any further ado, I think you all see the schedule for this evening, and what we're going to try to start with then this evening we have 2 wonderful keynote speakers. Then we will have a dinner break and enjoy some time networking. Then we will have a wonderful panel that will be focusing on crisis management and treatment resources in the area. So it's now my pleasure to actually introduce someone else who's going to do an introduction. So come on up, Dr. Roddy. Dr. Juliet Roddy is the James Wurgler Endowed Chair of Behavioral Health and Criminal Justice here at Northern Arizona University. And she has been involved in a number of different research endeavors. She's an expert in mixed methods research. She's been working in the fields of criminal justice and behavioral health for the past 25 years or so. Yep. And and also has a teaching focus on incarceration, reentry, substance use and recovery. And her research has been funded by NIH and SAMHSA. She is a member of the Ojibwe tribe in Northern Michigan. And again, we're really thrilled to have her here to do another introduction. So thank you, Julie.
Mine will be short. So hi, everyone. And let me begin by telling you how welcome you are here. I'm so glad that everybody's here. And of course, everyone has a different reason for being here, right? But many of us have come to hear Leonard Swanson's talk. I've come here to hear his talk tonight. That's the reason that I'm here. So my name is Julie Roddy, and I'm the James Wurgler Endowed Chair of Criminal Justice and Behavioral Health here at Northern Arizona University. It's funded by NARBA. I work with many of the people in the room to advance our practice and treatment of behavioral and mental health, and to pay particular attention on how our justice system and our health systems intertwine for good or for worse during crisis. But no one that I work with works harder and smarter than Leonard. Leonard is the crisis policy manager at the Center for Behavioral Health and Justice at Wayne State University in Detroit, Michigan. Leonard has a bachelor's of arts in religious studies from the University of Oregon and a master's in social work from Wayne State University in Detroit. From his degrees and from his title as crisis policy manager, you can accurately ascertain that Leonard employs multidisciplinary methods to understand our current approach to mental health crisis events, and he is unrelenting in his search to improve the system's response. So I invite you to enjoy Leonard's talk as much as I'm going to tonight. If you get a chance to speak to him, please congratulate him on his acceptance into the University of Chicago's PhD program in social work, where he will begin in the fall of 2024. It's all yours, Leonard. There you go.
Thanks for that, Julie. If it's any consultation, I know I'm not going to live up to that. So it's nice there. It's lovely to be here. This is a beautiful state. If you didn't already know, I got a chance to be in Tucson for a couple nights, see the beautiful saguaro cactuses, and then I got to go to the Grand Canyon, and of course it's magnificent, and saw some elk there. But then on campus, this is my first time really walking on the campus, and the only critters I saw were these little robots like driving around. I just wanted to kick them. I don't know if you all get that. I don't know if I was a college student and I had a few drinks on me. I don't know, but I don't know how you all managed to stop that. But anyway, not here to talk about critters. Here to talk about interventions for substance use disorders. So I'm at a center at Wayne State called the Center for Behavioral Health and Justice. There's a lot of us and we do a lot of work across the criminal legal system with people with substance use and mental health conditions. And kind of the purpose of our center is to use research evaluation as a means to facilitate change, right? We sit in between the world of practice and the world of research, where we can inform the research about what's actually happening on the ground and where studies should direct their attention. But then we also kind of inform the practice where we know that the evidence-based practices widespread. And so we help a lot with that implementation too. So I don't consider myself a real researcher. I heard most of the audience here is actually doctoral students. And so you probably have more formal education than mine. I'm going to change that soon, but so y'all probably all see the holes in the methods here, but hopefully this will give you an idea of some promising practices that will ultimately improve the lives of people with mental health illness and substance use disorders. So we found a lot of the work, kind of the rubber hits the road on a county and local level, right? There's kind of like broader state policy and state government funds us, whatever, but really the actual providers are on a county level. So our center did the tact of spreading out across the state of Michigan to know as many of these kind of county level people as possible, whether that's behavioral health providers or the law enforcement, or sometimes the jail, the sheriff's office, public health agencies, all that sort of thing. And so we split ourselves up. I live in Kalamazoo, which is sort of like the southwest part of the state. There really is a place called Kalamazoo. It does exist. Wayne State's kind of in the southeast. Most of the population is in the southern part of Michigan, but up north also pretty frontal rural. And so so I focus on crisis response interventions. So I'll talk a little bit about what that means, like alternatives to police response and traditional taking people to ED and kind of seeing what happens. I think there's ways to improve that, which I'll talk about here today. But we also do some kind of jail diversion projects, like how do you screen people for mental health and substance use disorders, or opioid treatment ecosystems, and different ways to get evidence-based practices to the people that need it. But I'll first start talking about post-overdose response programs. So we like to come up with funny little acronyms, right? So PROACT, proactive response to overdose and appropriate connections to treatment. And so why does this matter? Why is this an important issue? Well, if you suffer an overdose, you have a very high, your chances of dying in the following year are much higher, whether that's for another overdose or just general health concerns such as cancer, suicide, circulatory or respiratory diseases. And there's also the other risk of overdosing again. And so, what can we do about that? So someone overdoses, they go to an emergency department, or they go home, and we really, this piece, we struggle between, someone going home and then connecting people with care afterwards. But we know that people with lived experience can really make a difference in this space, right? So if you've been through the struggles of substance use disorder and you can talk about it and connect people with care, there's that connection can really be meaningful. So we try to bridge that gap between our traditional emergency response systems of law enforcement and emergency departments, and then the kind of treatment world with recovery coaches. So we did this in a few different communities in Kent, Monroe, and Calhoun counties. So in a lot of our work, we try to do some mapping of like what is the system of usual, and what are some areas we can do to intervene and intercept, right? And so at the top, you see our kind of traditional response to overdose involves fire, law enforcement, and EMS. People go to the emergency department and then kind of go home. So how do we make new connections such that people with lived experiences, recovery coaches, can intervene and have those meaningful conversations? And so you'll hear post-overdose responses are the main kind of ways to do that. But most of the programs we see across the country are led by law enforcement, right? Because law enforcement have this data and they're going up. So can people tell me why that might be an issue if law enforcement are kind of following up? Any ideas? Yeah. They're not trained, right? They might not, recognize the substance use disorders as much, or as such, or kind of see it as sort of dangerous behavior. Yeah. Any other reasons? Exactly, right? For the most part, drugs are illegal, or a lot of drugs are still illegal, right? You might have warrants, and that will create some trust issues. Any other reasons? Exactly. Yeah. So they approach the situation with a different lens, right? And so, first responders do see a lot of horrific things, and kind of one coping mechanism is that they start to get, and this is true of other professions too, is you get jaded, and you start to kind of see people as it's how kind of stigma breeds and builds up, right? And so then there's kind of a distrust and difference within the community. So how can we get these referrals from our first responders to these kind of more follow-up agencies? There was our big question. And so the model involves recovery coach really making follow-ups to folks' homes. They can offer naloxone, fentanyl test strips, syringe exchange if those services are in that county. Xylazine test strips. Is xylazine a thing around here? I know it's popping up in Michigan a lot. Yeah, we're seeing that a lot too. Yeah, horrific stuff. So the more we can kind of get more treatment resources in the hands of folks, the better. Or if they're not even ready for treatment, what kind of harm reduction stuff are they ready for? It's not, always widely known. But if you're in the space, you might have heard of a thing called HIPAA and 42 CFR, which is, our big question. How do we bridge that gap? So this is probably the most boring part of the presentation right here, but it's one of the more important. So because how do we address this legal barrier between EMS agencies and the kind of providers, right? So HIPAA is a thing you'll see in the MMHC. Don't worry about that. This Michigan Mental Health Code doesn't really apply here. But one of the first things I want to point out is 42 CFR, right? That's the for those unaware, that's the more like the stricter data sharing laws that limit the sharing of name information, contact information of people with substance use disorder, which is good, right? I mean, we don't, there's stigma around it. People don't always want other folks to know about drug use. But what's important to see here is EMS actually, that doesn't apply to them, right? They don't hold themselves out as behavioral health treatment providers, and they're not federally funded. So really, we only have to deal with HIPAA and kind of state laws about that, right? And in Michigan, we were able to work with the rep that I've been talked to said it's horrible and it's no fun. You don't want to talk to anyone or sign anything. So, there's legal question of like, can they really give consent if it's in that state of mind? Or, and it's just from a practical matter of like getting people to sign a form right after they've been resuscitated. It's pretty rough. So, I mean, EMS is just sitting on all of this data with these with a list of people really high risk of death, and without any sort of intervention, they'd risk, either they'd risk dying or a subsequent overdose. So we took the matter of like, how can we actually get this transfer of name and follow-up information to recovery coaches who can at least offer support and if they're interested, right? And so there's pieces in HIPAA and at least Michigan Mental Health Code where for the purpose of treatment activities of healthcare provider and for coordination of care, you're actually allowed to send names over to these treatment providers. Now, I'm not your lawyer, and don't ask me to defend this in court. And it's by no means like settled legal territory. It's one of those gray areas, but we found that an EMS agency lawyer who was willing to back that up based on the compelling need on a substantial probability of harm, right? If nothing else happens, there's a really substantial probability of harm for someone to die or have serious health concerns. And of course, we as researchers, if you're in this field and you're doing research in the study, there's like, wait, you can't take names. And it's like, well, there's certain stipulations that say we can, because we're not going to mess with it. But once we get all through the IRB stuff, we can do some exciting interventions. So up here, you'll see a graph of in one of the counties that we worked with, the kind of green line is EMS naloxone administrations in that particular county. And you'll notice when we start the EMS referrals to overdose, when we got that legal opinion, you'll see that yellow line of referrals to the CMH or that kind of harm reduction provider really go up, right? And so we, this isn't too sophisticated methods, right? We didn't like run a regression or do any t-tests or anything like that. But it was a way to kind of show the data to the county partners to be like, how do we work with this? How do we kind of improve our referral mechanisms to really make something happen? And so in this county, we were able to get a number of people referred to treatment, which is good. You'll see that kind of spike toward the end where we looked at the different referral criteria of, we went kind of beyond the naloxone administration and went to sort of any suspected drug use, and it shot up a little bit. And maybe that was, kind of too difficult for the partners to respond to all of them. But so some more work to do there about like kind of refining the criteria. But we were able to get a lot of people at least sent to CHER. So, among those, so this is among 3 different counties now. We were able to get almost 1,000 people referred to the treatment providers. But if you've ever worked with like real world administrative data like this, it's not pretty. There's a lot of missing pieces. So about half of them actually were unusable. So they didn't have enough name information, contact information, right? I mean, if you just get resuscitated from an overdose, again, you're probably not going to want to talk to anyone. Are you really giving your real name? Are you really giving your real phone number, real address to follow up at? In some of the cases, yeah. But in some of the cases, it just wasn't usable. Some of the folks did pass, and sometimes they just used Narcan. And it didn't actually have to do with the opiate use disorder, but about half of them we were able to attempt contact. A good chunk of them didn't answer their phone, right? If you get a call from a random number, not likely to answer, which is fine and understandable. But some of the attempts were like in-person contacts, and so they got in touch with their family and friends, and that was a bit of a delicate conversation about who they were, why they were there, and they were kind of mum about disclosing too much. But with about 200 people, they were able to have direct conversations with the person who overdosed, which is positive. And so what happened in those 202, the people with direct conversations? Well, about a quarter of them kind of refused everything. They're like, thanks, but no thanks, close the door. But most of them were open to receiving resources about harm reduction, fentanyl test strips, even just information about the syringe exchange program that was nearby, if they had one. Just open the conversation, which was promising. And then almost half engaged in some sort of recovery coaching, outpatient, inpatient treatment, which in this world, we're pretty excited about that level of engagement, which is it's a really tough population, really high risk. So we're happy to see that level. The in-person outreach was a little more promising than the phone-only outreach, right? If you see a random number that you hadn't seen before, they don't always answer, but about half the time the in-person outreach worked out. And there's a few differences by site about how they chose to reach out. So we wanted to do a little more. We tried to do some mixed methods in this study of actually talking with the people who survived the overdose attempt and actually got one of these reach outs and wanted to engage in care, just to hear a little bit more about the stories and how they made the decisions. So I'll admit this is a pretty biased sample, right? So this is the people that not only got in touch with the recovery coach, but then engage in services afterwards. So it's kind of cherry picking a bit, but I think those are stories still worth listening to about what was going through your mind as you were calling 911 and as someone knocked on your door, right? And so we gave gift card compensation, and interviews are about 45 minutes long. And they talked about their knowledge and experience of 911 responses. So, what were their hesitation to call 911 at all? Of course, these are all people that did make that decision to call 911, but ultimately said, if it's about saving a life, you don't want that life on your hands. But they also talked a little bit about that stigma, right, of the first responders. So, they look at you like you're a druggie, or it's the verbiage they use and the way they carry themselves. It's different than the way Red Project was the service provider in this area. It's different. So, like as Julie mentioned, fear of arrest, fear of CPS involvement, the confidentiality piece, which we'll get to in a second, and then that social stigma. It's a real concern, right? And so, this kind of touches on later. Like, man, I mean, if most of these post overdose responses are kind of led by police, it's and having them knock on your door, it'd be concerning, wouldn't it? So what was their first impression like? So it was actually pretty surprising. First time I was like, if it's the cops, I'm not coming to the door, right? I mean, that's a pretty, wasn't aware of it, but thankful for it. Didn't feel an ounce of judgment. Made me feel a lot less anxious about talking to someone and getting help, right? So this kind of supports the research we were hearing earlier about recovery coaches being really accepting and thoughtful and just empathic ear to talk to someone who's going through a really difficult time, right? They weren't trying to push a particular treatment agenda, weren't trying to get them into some self-help groups or anything like that, but was just kind of giving resources. And that recovery coach was there on an ongoing basis too, which is really nice. They had someone to talk to, someone to text, knowing that they were there for a resource, and having that support was really solid, accommodating transportation needs. If you've ever met a good peer recovery coach, I mean, some of them can really kind of go above and beyond and really pour their heart and make these kind of meaningful connections, which is kind of missing from our traditional first response systems, right? And then some of these life story quotes just really pull at your heartstrings and makes you thankful to be doing this kind of work, right? Changed my entire life completely. Went from being a severely depressed addict, no hope for myself and getting my future to getting my life back on track and getting clean, looking forward to my future. I mean, that's what you want to see, right? Had some feedback for the group. I mean, the agency we were working with, you know, they were very, like, if there's a spectrum between on the very treatment side and very harm reduction side, they're pretty close on the harm reduction side, if you know what I mean. So they weren't exactly pushing MAT resources. I mean, I know that's a solid evidence-based practice, but at least this agency was a little shy about you know, proclaiming what the right steps to do, which is it's a worthwhile discussion and good argument there. But just having access to resources at any hours, you know, ways to improve the group. And then we've got, you know, our interview questions there. So overall, the EMS sits on a lot of really valuable overdose data, not just from a research perspective, but actually like meaningful following up and providing really good interventions with folks. We don't want to see police officers involved in the response. I know there are some harm reduction agencies and mental health agencies that are nervous about going to calls or to residences that they're not familiar with. And I can understand some of those concerns, but you know, going with two folks or working with people that kind of have lived experience in that sense, I think really being able to offer that kind of non-law enforcement response is quite meaningful. Really, we're aiming for that kind of 2 to 3 day follow-up. There's a little quote about that. You know, if you wait too long, you risk another overdose, but if it's too quick, the person's still sort of in the middle of processing the moment and might not be kind of open or receptive to thinking about larger decisions. But and there's other models too. I mean, this isn't the only model of how to respond to someone after an overdose. Like, I know some emergency departments have peers and recovery coaches there as well. So I think this can kind of work in tandem to reach out to as many people as possible there. Okay, so that was post-overdose response model. And it's not really, those post-overdose isn't really initial response, right? We wouldn't think of those as first responders, but there's a lot of exciting models out there that involve responses other than law enforcement as a first response, right? So what's going on with those? Where are they at? Where's the research at with them? So we like diagrams and to make fancy things like that. So I'm going to try to walk through this one. Lots of different, you might have heard like lots of different terms about different models going out there. So there's mobile crisis, there's community response, there's co-response, there's CIT. What are these things? And so we made this diagram to kind of demystify this new and exciting world where people are kind of throwing money at the problem, which is good. Don't stop throwing your money at this problem. It's a very important one. But like, what does it actually mean? What are we talking about when we use these terms, right? So if I walk through this on the left side, we're talking about non-police first response. So I say people familiar with the sequential intercept model. This is like before we get into law enforcement response, right? On the right side are models that involve law enforcement somehow. And the point of this circle is not to say which is the best model. I think we need a little bit of all of these models, right? There are a chunk of 911 calls that do not need a law enforcement as first response. There are also cases with mental health and substance use where we do need a law enforcement response, in my opinion. I mean, if someone's wielding weapons or if someone has active threats of violence, like I couldn't in good conscience recommend you know, an unarmed person going to certain those situations. But so we need to get smarter about thinking about which situation belongs for which sort of team, in my opinion, right? So on the left side, you'll see the high risk of active violence involves law enforcement somehow. So on that bottom right is kind of most prevalent model of crisis intervention teams. This is kind of the most prominent model of training law enforcement. It's about 40 hours. They go to 911 calls and it's predominantly law enforcement. On the top right, you'll see co-response. So again, this kind of high risk of active violence where the law enforcement is there, but you also get the benefit of bringing a mental health professional, whether that's a clinician. And sometimes they go to calls originated through crisis lines, but they can also go to 911 calls as well. And so on the left, you'll see civilian models. So mobile crisis is, they're pretty prevalent. I mean, there's hundreds going on in the United States, but we don't really see them as often as we see like an EMS truck or a law enforcement car, right? But they're usually run by the mental health system, and they involve a clinician really focused on the question of, does this person need to go to the hospital or not? Which isn't the only question, but it's the question they're sort of directed at because of billing reasons and what have you. But there's these newer models popping up, and some are older than others, but community response models. So if you've heard of either Cahoots or STAR in Denver, these kind of, they take on kind of social needs calls. It's not really about whether the person needs to go to the hospital. It's just like, can we give them some clothes, or like give a water bottle up? Or if like someone's, you know, waving their bags of things on the street and someone else is concerned, or someone's speaking loudly in a Starbucks or coffee shop, you know, there's mental health involved, but it's kind of social needs are sort of underpinning there. And so you know, some models are bringing clinicians, but I think where we have in here service coordinators and medics are on those calls too. So we don't actually have a community response model in Michigan, but I know they're kind of popping up nationally. So this is kind of how we've been thinking about what goes on here. And then we wanted to see kind of what was actually happening with a few of these models coming up in Michigan, right? So you'll see the mobile crisis and co-response terms there. There's one community that didn't have either of those and just did kind of office-based crisis. And so we wanted to do a little deeper study of kind of what happened when those models were there. And then we also collected data from law enforcement agencies in those same areas to see what happened when law enforcement actually did some crisis response there too to mental health crises. This is probably way too much information, but it's a little bit more about, you know, who's, you know, what population size, where they got their funding, each of the different models in the counties. There's some mobile crisis going on. And some of the, I guess the only point tomorrow is this, yeah. So a lot of these kind of advanced models had like millages and extra money from their local municipalities. So they were kind of the richer communities, right? I mean, if this is a conference about equity, I want to be sort of upfront, like the richer, wider areas could afford these kind of advanced models of getting more clinicians on the street, whether that's like this kind of bigger mobile crisis, or the law enforcement were able to hire their own clinicians and do this kind of co-response model. So I think long-term equity-wise, our center really wants to see what the interventions look like in areas that are less well-resourced. But I thought it was also an important question to see, okay, with this fully funded thing, what's actually happening, and is it worth the investment in other places? So a little bit about how we got our data. So we started on the law enforcement side with dispatch calls, and then we picked out police reports that had to do with mental health incidents. Like sometimes they had a code for it, sometimes we had to do some keyword searches, and then we took a random sample of that. We didn't have the IRB set up to do youth stuff, but this is the kind of sample across all those communities. And then we kind of separated them, whether they're pickup orders and mental health emergencies. You might have a different term for this, but like if a court orders someone to go to an emergency department, we sort of excluded that and put it in its own category. Or if there's a medical emergency, like if someone swallowed a bunch of pills, or if they're like bleeding profusely, kind of got to go to ED, right? So we kind of put that in a separate category versus live, where it was kind of, we didn't really know what was going to happen. And on the mental health side, so we use CMH, that's our kind of public mental health agency in the area. And then we picked out crisis services. So we used some Medicaid billing codes to pick those out, or if the co-response team had like an Excel spreadsheet, we picked those out too. And again, we got our kind of random sample. And then we took out the cases that happened at emergency departments. And then we split kind of follow-up responses against the live calls. Like, were they going right when the crisis was popping off, or were they kind of doing some follow-up work, and sort of split some calls there. But we got a few hundred in each of the categories. So a few demographic information. So I'll start with the age side. So the green is sort of the county census data of the places that we did the interventions. And on the left side of the kind of age graph, you'll see a huge skew on the younger side, right? Makes sense. You might have heard that young people are having a tough time mental health wise. And you know, we weren't able to get data for people under the age of 18, but really skewed young, both on the adult side and the mental health service side. The slide's a bit messed up on here, but most of our folks are Medicaid or on Medicaid, when we could tell that sort of gray area, it was missing data. So, among law enforcement, law enforcement reports aren't going to know that insurance data so much, but Medicaid was the primary one. So linkage to ongoing care. We'll start kind of on the left side. So the darker shades are when the crisis agencies actually set up a follow-up appointment. So not just giving them a referral card, but actually saying, this person will talk to you at this date and this time. I've got on good authority that thing's going to happen, right? So about half the time that happened, which was nice. And then that kind of lighter shade in each of the colors, at least hand out a referral card if they weren't setting up an appointment. On the law enforcement side, it looks like my slide is a little messed up there, but it'll say, a vast majority, they notified the emergency department only. So that kind of the lighter kind of middle blue shade is the traditional, what law enforcement are used to do. They don't actually know the mental health resources in the area, but they know emergency departments. And that's the standard thing that they do. You'll see that kind of darkest blue shade of notifying the mental health system. That happened about 10% of the time. Half they did a live call out where a clinician would actually meet them there. But some of the time it was just a referral, right? So this difference alone, right, of actually setting up the next thing to do for a person in crisis, pretty meaningful. Follow-up responses. This is probably a little bit too hairy to get into too much detail, but that brown one. So like each of these different groups of bar charts, the number of follow-up attempts that happened. So the co-response, they're pretty standard practice to do at least one. But they almost never did 0 follow-up attempts. But the other crisis models, like the mobile crisis and office-based, about a third of the time they didn't offer any up, but also a chunk of the time they did a lot of follow-up care in the days following, right? And so I don't know if folks in here have been through a mental health crisis or substance use crisis, but it just doesn't last a day, right? There's pieces to collect, there's things to address and sort of de-escalation and just resource connection and ongoing conversations. Hey, are you doing okay? I know that was a rough incident a few days ago. So this kind of follow-up care, I think, is the biggest piece missing from our traditional side. Yeah, it's a good question. I don't even know how I would measure that, but yeah, I mean, the classic definition of a crisis is when someone's when a situation exceeds someone's ability to cope, right? So we all have kind of coping mechanisms, right? If we're going through a tough time, like I like to do some workout or meditation or talk to someone, but when that stuff doesn't work anymore, then we're in crisis mode. So crisis can get pretty severe in just a few days. Yeah, more than the day, I think. Yeah. We looked a little bit at the law enforcement reports, and this was reading through narratives of these. And if you ever had a chance to do this, I mean, there can be some pretty rough stuff in there. I know my staff have had to take some time to sort of decompress after seeing the things that are in there. But we wanted to see like how many of those law enforcement calls actually involved threats. So about half the time it was threats to self. Sometimes they have threats to other folks as well, right? About 20% of the time. But these are the level of calls that would make it to a police report. Like sometimes they just kind of law enforcement will just see someone and then hand them off and then move on. But if the cases that we were able to actually look at and read the narratives about, they kind of rose to the level of a full report. And so it's probably a little more dangerous than other calls, which, is another big limitation of this study, right? I mean, the cases that law enforcement are going to and comparing that to the people walking into a mental health office, not quite apples to apples, but it's at least worth seeing what's happening when these two different responses show up. So we looked at a way to tell, like how could we tell whether these office-based or mobile crisis cases were escalating, and we looked at 911 calls. It was a majority, right? 3 and 7%. Interesting, we saw that the white folks were more likely to have law enforcement called on them than the black folks in these crashes, which is not what I would assume, but it's what the data was telling us. This one's pretty rough. So the incident escalation. So we wanted to see whether use of force was involved. So you'll see the kind of pie chart on the law enforcement side and the pie chart on the co-responder side. Really, the darker blue means there's some sort of force used, right? I mean, you don't need the numbers; you can kind of see what's going on there. And then, so on the co-responder side, it was about 7% of the time. Law enforcement, it was closer to about a quarter of the time. There's some sort of force used. And then we wanted to see kind of what were the types of force used. So whether it was just handcuffs or it was like open hand control, or less than lethal methods. We didn't see any lethal methods in our sample here, but really, I mean, you can see the difference, right? I mean, there's more use of force in law enforcement cases, but again, it's not like we randomized it, right? We didn't have a coin flip of whether co-responder showed up. It could have been they sent the safest calls to the co-responder model, and we just looked at the traditional law enforcement ones. In general, people that were male and people that were younger were more likely to have force used against them. And this was like where was the folks actually transported to? So when you transported to the emergency department, I touched on this earlier, right? I mean, that's the traditional law enforcement response. And so that was about 70% of the time law enforcement would take someone to the ED, whereas these other models, it was much smaller. So there was about, a third of the time for the office-based mobile crisis and about half the time for co-response, right? Which alone is a huge difference. So if you're able to de-escalate a situation on scene without having to take someone to an acute resources, that to me is a meaningful difference there. We also looked at sort of transportation and mental health treatment. Again, the co-response areas, they had a little more resources to them. And so they had actually like a law enforcement drop-off center, which was nice. And so we saw a few more there, and then arrested some of the co-response. Law enforcement, we saw a little bit there. But really the takeaway is office-based and mobile crisis really able to resolve on scene a lot more. But then on the law enforcement side, when we look at the transportations to emergency department, we looked at whether those were voluntary or involuntary. And I know the slide's all messed up, but about half of them were involuntary, or in Michigan, we say petitions. So like, you have to go to the hospital because I'm law enforcement, I'm sending you there. So that's kind of troubling too, right? I mean, if we look for certain language in the law enforcement reports, and they would often put petition in there. And I guess that's another limitation too, is like, we didn't actually get to hear from the people that were in crisis. This is just the story of the law enforcement kind of writing out what they saw and what they did, which is, of course, could have a bias to it, but it was all the information that we could gather. So takeaways. So the advanced kind of mobile crisis and the co-response, these were the areas that had money, right? It wasn't just Medicaid and it wasn't just general fund dollars. They actually had extra funds for people to go out and do the services, right? Because if it's just a fee-for-service model and you can only go for the Medicaid population, that's going to be really restrictive, and you can't just hear about a crisis and ask who their insurer is. I mean, we can't be doing that, right? I mean, that's not how EMS works. Not that we should replicate the EMS system either, but they had an extra pot of money to be able to do. We call it a firehouse model, kind of being ready for a crisis to happen, not just being reimbursed by each particular incident. Again, people in crisis tend to be young, so it sort of reinforces what we have been hearing in the major news outlets. It's a thing, and we're going to need some more kind of specialized services for youth. Again, those kind of crisis response models able to de-escalate on the scene and sort of avoid these more acute crisis services down the line. And again, our comparison groups weren't great, but the law enforcement sample, we saw some more use of force and struggles to connection with care afterwards. So this is all like what happened during the scene. We are in the middle of doing some kind of long-term outcomes. What happened to the person in the following year, right? So we're thankful to have some arrest data, and Julie and I are working on, exactly how we think about that. Short answer is law enforcement side got arrested more. Was it exactly because of the law enforcement mobile crisis model? Hard to say, or, we still got some more work to do in sort of, isolating that and working on the publication there. But the other piece we want to look at is, what did treatment continuity look like? Can we see some more Medicaid billable services in that following year? What about emergency department visits? Are we able to show fewer on the crisis side than we are on the law enforcement side? And psychiatric inpatient is another thing to look for. That can be a very high level of care, and in certain circumstances it's necessary, but You know, if we can avoid that intensity, because it can be quite traumatic for folks to go through that psychiatric inpatient, the more we can avoid that, the better, in my opinion, too. So that's where we're going. Hope to de-escalate, and I think I'm open to questions here.
Y'all have questions over so those online can hear as well. I'm gonna run.
Because I'm deeply afraid of work, right? I want to know what's going on. So here, Leonard, what we have is a mobile unit that involves a community mental health agency, Teros here, and fire department. They kind of ride around. They wait for calls, but they also proactively intervene. One of the things that does concern me is when they're sent someplace, all of the calls come through police dispatch. There's one dispatch space. So it's law enforcement making a decision about what those calls get funneled out to. Do I call that unit co-respond? What do I call that unit when it begins with law enforcement dispatch? And do we have any information on that?
Yeah, I mean, the exciting thing about this field is that people are trying all sorts of things like that, and there's really not much research. So I'm not going to point you to a study where it says this is the right answer for your community, right? But there are some principles we can kind of think about, right? So, you know, the information I was talking about today is just in this kind of area of people that go out physically to meet people at calls, right? There's a whole other emerging field of what happens at a 911 call center, what happens at crisis lines, where we can not only train the folks there that are already doing and receiving those calls on you know, how they can de-escalate over the phone, but then what are the kind of calls you can link to these kind of units that you're talking about, right? And so I would hope that you know, and one of the most exciting models I think is actually embedding a mental health professional in a 911 center so they can help with the ongoing training efforts of, no, this is a call that we actually don't need to send police to. This is a call that's really suited for this model you're talking about with the EMS and the clinician, right? That's going to be a lot of cultural work to do. There's a lot of, you know, I don't know if you've ever been in a 911 center, but they're really focused on their work, and it's a fast-paced environment, and they don't quite see situations the way mental health professionals do, right? And so I think there's a lot of work in sort of unpacking, you know, what are the right kinds of calls, so that in my ideal future, we can safely call a 911 and have confidence knowing that certain situations are going to be routed appropriately. Now, is that the case right now? Like if you have someone in crisis right now, there is a risk of sending law enforcement, right? I mean, I'm not going to lie to you, right? And that's what they're used to doing. That's what they're comfortable doing. It's what they're legally suggested to do for liability fears and all that. So I know there's kind of the 988 world of this alternative line to send crisis calls to, where right now it's better at sort of de-escalating calls over the phone, but 988 is struggling a little bit to actually route calls to these alternative units. I guess Arizona is an exception. They've got a pretty good 988 system here, but so if you're asking me for advice, Arizona, I would try 988 for 911.
Are there any other questions online?
I've worked in law enforcement for a long time, and one of the concerns that I've seen working in both health and justice is when you embed an individual, no matter what their profession, in the building of the other profession, and they're employed by that agency, they adopt the culture, the mannerisms, and all these other things, and become a piece of the justice side. Even if they're a health professional, or vice versa, if they're a law enforcement professional, they adopt a health persona, and they don't act in the way justice or the way health does, or as a quasi in between. Do you know of any research that's been done on the personality changes of working in an environment like that?
Yeah, it is a common issue. A lot of social workers are sort of raising that. It's like we don't. So some social workers are really against this model of being hired by law enforcement to sort of. I don't know the right way to say this, but I mean, we were seeing a huge growth in Michigan, at least in the co-response model of law enforcement, just hiring their own clinicians because they have the funding and flexibility to do that. Now, is that good? You know, I think there is some promising data, at least here in the co-response model, but I think there are those cultural concerns that you bring up, right? I mean, people can get jaded and stigma can grow. I have seen a model that it works. I mean, it takes a strong personality for a social worker to kind of stand up for social work principles and you know, really drive that culture home of what we want our next system to look like. I haven't seen any studies done on the actual cultural impact of what it would take for that clinician to do it. But I think that is another reason why these kind of community responder models are pretty exciting, right? It's usually they're entities housed separately, sometimes in fire and EMS worlds, sometimes in mental health systems, but sometimes in sort of like separate nonprofit health agency, which I think is pretty exciting. But then you got to build the trust of being able to take on 911 calls and being able to, that law enforcement are willing to pass you on a call and not feel like they're getting themselves in trouble too. So lots of kind of cultural bridging that's got to happen somehow. And I'd say it's an unresolved question about whether it's harms for embedding in culture, but it's a real thing. Yeah.
Well, thank you. Thank you for joining us back. And we had a great first presentation, and now by Leonard Swanson. And now we have Dr. Cynthia Khan, who's going to do our next keynote speak. Dr. Khan has a long history with NAU. She came to NAU to get her bachelor's degree. And she fell in love with Flagstaff. She did leave because at that time, and even currently, we did not have a medical school, though that might change in our future. So she fell in love with Flagstaff. She went down to Tucson. She got her medical degree and then did a residency in emergency medicine, all in Tucson. After her training, she came back to Flagstaff, and she's been here for 22 years. She has two young girls, and her husband is also here in the audience. And just a little secret, today is their 26th anniversary, and they get to spend it with us. So she worked in emergency. She worked as a physician in the emergency room, and in 2020, good timing, she served as the head of ER physicians. I can only imagine how that might have been at the Flag Medical Center, where she still serves as the head of that division. So we're so pleased to have her, and we look forward to her talk. So please join me in welcoming Jen Khan to this podium.
Great, thank you for having me today. I was very interested in Leonard's talk about what's going on outside of the emergency department in Michigan. It's so important that those resources are being examined and made as robust as possible. It was a great talk. I was asked to talk today about substance use disorder patients in the emergency department, and I was asked to talk about some ideas for future. So let me jump in. First, a disclaimer. I am a partner and part owner of Flagstaff Emergency Physicians. We are not employed by the hospital, but we do contract with Flagstaff Medical Center to staff the emergency departments in Flagstaff and Cottonwood. And my group has staffed Flagstaff Medical Center for 50 years at this point. Very long time. So since right before 1974, 1975. So very, very long time. Dr. Malat talked a little bit about my background, that, I did go to NAU. I lived in North Morton, right across the street. I parked my car in well, there used to be a parking lot right here. And I worked at Flagstaff Medical Center as a unit secretary before I went away to medical school. So it was a little bit of a homecoming coming back to Flagstaff Medical Center after completing my medical degree and my residency training. So let me talk a little bit about physician training. Anymore, the emergency department is a bit of a catch-all. When a patient needs help and they have nowhere else to go, they come to the emergency department. So I think it's important for us to talk a little bit about physician training and specifically training in emergency medicine. So in medical school, years 1 and 2 are primarily in the classroom. Anymore, we're trying to get students out earlier and earlier, which is always appreciated by the students. But the first 2 years really focus on those core subjects that I've listed here. One of those core subjects is social and behavioral sciences. As we move on into year 3, third year clerkships are 4 to 6 week rotations in general surgery, pediatrics, family practice, et cetera. One of those rotations is psychiatry. So now we've got, got at least a focus on in years 1 and 2 and a small focus in year 3 for psychiatric illness. Year 4, however, is focused solely on what that prospective physician is interested in. So if someone's interested in orthopedics, then they're going to do a 4th year that is solely comprised of surgical rotations. There is not going to be any sort of general medicine in those clerkships in the 4th year. During that 4th year, medical students have to decide what they want to specialize in because everyone has to choose a specialty these days. There are no more general practitioners. The military is a little bit of a caveat there and a little bit of an anomaly, but for the most part, there really are no more general practitioners. Everyone has to match into a specialty. So after everyone graduates medical school, they start a residency program. Emergency medicine is a 3 or 4 year residency. We typically do rotations in emergency medical services, anesthesia, OB, cardiology, toxicology. And you can see that psychiatry is not one of those rotations. I know of one program that has an addiction medicine rotation, but that's pretty rare. I'm sure there are more out there, but it is pretty rare to actually have addiction medicine. Most of our addiction medicine training comes from the actual emergency department rotation itself. So, we are really focused on the medical stabilization of patients and not really the mental health care of patients, which we leave to our psychiatric colleagues. So when substance use disorder patients come to the emergency department, we really focus on their medical needs. Thankfully, most patients do not require a medical admission. But once we stabilize that patient from a medical standpoint, we really don't have much more to offer that patient in the emergency department because we just don't have the resources. So from there, we consult behavioral health for mental health recommendations. Options for patients can be really variable. It really depends on what emergency department you walked into. If you were in an urban center that might have a lot of local support, or if you were in a small, rural, geographically isolated emergency department that wasn't staffed by a board-certified emergency physician, might be staffed with a locums physician who doesn't know the local resources. Perhaps it's the charge nurse and not a behavioral health intake social worker who's helping to achieve placement for a patient. And so, options for patients can really be highly variable. So let's talk a little bit about the Flagstaff Medical Center Emergency Department. So we are fortunate enough to have 2 sets of behavioral health social workers. We have both the Flagstaff Medical Center Behavioral Health Service, as well as TEROS, which is a contracted service. So if a patient needs admission for psychiatric reasons, our social workers send out packets, they make phone calls, they call facilities, they try to arrange placement for our patients. And sometimes these patients board for hours or sometimes days in the emergency department. And I think it's really important for everyone to understand that we don't have any therapy, counseling, or psychiatric consultative services in the emergency department while someone is boarding. They literally just sit and watch TV. There's just a total lack of resource there. Typically, we cannot place patients with substance use disorders from the emergency department. And I'll get into that a little more next. But our behavioral health social workers really do try to arrange the best case scenario for our patients. I'm very thankful for our BH social workers and for Teros and all they do for us and for our patients. And they really do try to arrange timely outpatient follow-up. So I'm going to jump into some stats from the emergency department. So on the left-hand side, you can see the number of ED visits per diagnostic category. So on this column here is alcohol, followed by opioids, followed by stimulant abuse. And then on this side, you can see the distinct number of patients per category. So, you have a total of 2,770 alcohol abuse patients that are over age 25, and a total of 1,089 patients responsible for those visits. And then I know this is super busy, but I thought that this was a really interesting slide. So this is the same information from the previous slide. And I apologize, I didn't put this slide together. This came from business analytics at Flagstaff Medical Center, and the columns are reversed. So on this side, you have the visits, and on this side, you have the distinct number of patients. But this breaks it down by race and ethnicity, as well as by age. So on those previous slides, you could tell that alcohol is by far Flagstaff's biggest problem. We had 3,037 visits roughly by 1,330 individual patients. We probably had more, quite honestly, but our ability to figure out how many visits we had is solely dependent on the coding that happens. And sometimes patients get coded differently. And so instead of someone getting coded as an alcohol substance use disorder patient, they may get coded as altered mental status. And so we might miss that patient. So anyway, so 3,000 visits by 1,300 patients, 636 of those 1,330 patients were Native American. And I think it's important to note that 10 patients make up greater than 10% of the visits. We sometimes have patients visiting us 2 or 3 times a day in a revolving door phenomenon. And I know the thought might jump into your head, well, why don't you just take care of those 10 patients? Well, we do. And another patient pops right back up into their spot. And so it just seems to be a revolving 10 patients, no matter how we try to attack the issue.
Yeah, did you say that was last year?
This is for calendar year 2023. Yeah.
Can I ask a question?
Of course. Yeah.
By far the Flagstaff biggest problem is
No, alcohol is the biggest substance use disorder problem. So versus opioids versus meth.
Okay,
Yeah. Yeah. I'm sorry if that wasn't clear. Yeah. So when we're talking about alcohol substance use disorder, we're talking about 4 different categories of patients. So the first category, and probably our category that gets the most press are the found down intoxicated patients. So these are the patients that are intoxicated in the community and get brought in via EMS. The second category are patients that come in through triage looking for detox. And, this is the, population where we, hope to really make the biggest impact. The third category are those trauma patients who have been in a car accident or had a fall that had also consumed alcohol prior to arrival. And then the last category of patients are the patients that present for jail clearance who simply blew too high. They were refused by the jail. So as we talk about that first category of patients, those patients that were found down in the community intoxicated, we have about 8 or 9 intoxicated patients sobering in our ED beds, if we have beds available, or in our hallways every day. Because the treatment for alcohol intoxication is time. I mean, someone just needs time to sober up. So we, put a pulse oximeter to measure their oxygen content in their blood on them, and we watch them as they sober. We don't currently have a local sobering center. It's difficult to stand up a sobering center. No one wants it in their backyard. So previously we had the intake triage unit at the guidance center, but currently that's not available to us. So our patients, like I said, just typically sleep it off. And when they sober up, they typically don't even tell us that they're leaving. They typically just get up and just walk out of the emergency department. If we're lucky, we do catch them before they go. But most of the time they just walk out. So this does create that revolving door phenomenon. We don't even have food or meals in the emergency department anymore. So I can't even say that these patients are coming in looking for a turkey sandwich. We really, don't have much in the way of 3 hots and a cot to offer them. As we're talking about the patients that come in through triage that are looking for detox, we typically consult behavioral health intake social workers to come and talk to our patients. And they sit down with our patients and they make sure that they have an accurate listing of local AA meetings. They talk to them about potential residential treatment programs. I've listed just one of the offerings that's a potential, that Back to Basics program. That one's only for young males. It's also pretty cost prohibitive. The guidance center steps up and really does a lot for our substance use disorder patients. They have an assertive community treatment, an ACT RN. They offer a peer support program. There is a halfway house available, but medical detox is not available locally, unfortunately. The closest services are in Prescott or in Phoenix. And really, we only have success typically in placing patients in Phoenix. There are no programs for adolescents. And a lot of times when we're trying to talk about detox for patients, we have trouble placing them because of insurance. Most people think that they have great insurance until they try to access services, right? And then you figure out what your insurance covers and actually what it doesn't cover and what your out-of-pocket cost is going to be. And that is typically a barrier as well. Outpatient rehab services are available at the guidance center. Talking about a residential treatment program, but it's, very popular program because we are so geographically isolated here in northern Arizona, and there's typically a 3 to 4 week wait for that program. If you are pregnant, they do bump you to the top of that waiting list, but there typically is that wait. Our trauma patients that come in due to a car crash or a fall that need to get admitted do receive consultation by our behavioral health workers and SBIRT screening. I don't know if you're familiar with that, but it's screening, brief intervention, and referral to treatment. And so we feel very fortunate that we do have this this program in place for our trauma patients, because that's a great teaching moment and a moment of intervention for trauma patients. And then our last category of patient, the jail clearance patient that simply blew too high. These patients come to the emergency department in custody with a police officer. The police officer is looking to get them in and out of our facility as quickly as possible, because they need to get back out to their work. We don't really have any opportunity to intervene with these patients at all. As I was doing research for this presentation and talking with some of our behavioral health intake workers, they talked about the old DUI court and the recovery court program. Dr. Roddy probably knows way more about this than I do. But I felt like it was worth mentioning this voluntary court supervised substance use treatment program for people with criminal offenses. This could be for any substance, not just alcohol. There's a designated recovery judge and public defender that work together and enroll patients in this program that lasts 15 months. There's a 78% graduation rate, which is wonderful. And many of these people graduate with new employment. Felonies become misdemeanors or charges dropped altogether when they graduate this program. And certainly relapsing patients are also helped as well. And there's an attempt to place them in residential programs. All right, so I'll shift gears a little bit and talk about opioid substance use disorder. Compared with alcohol, where there were over 3,000 visits, we only had 123 visits for opioid use in the Flagstaff Emergency Department, which is honestly wonderful, right? That we live in a community where opioids is not as big of a problem as it is in other communities. So 123 visits by 99 patients on the calendar year 2023. Most of these patients are not coming in our back doors. Most of these patients are coming in our front doors. These are patients with chronic pain and an inability to obtain narcotics. We do occasionally get opioid overdoses via ambulance. Those patients that are, woken up with Narcan, sometimes they're so intoxicated with an opioid that they need to be placed on a Narcan drip and admitted to the ICU. But that's not common. Most of these patients are coming in our front doors. They're medically stable and they're looking for help because they can't find help elsewhere. If you've been practicing medicine as long as me, I'm sorry, I'm looking at you, Sarah. In the 1990s, the Joint Commission, so the Joint Commission, JCO, is a credentialing body that helps to credential hospitals. They made pain the 5th vital sign. They felt like pain was really undertreated in America. And so there's this big push to aggressively treat pain in the United States, especially in emergency departments. And doctors were encouraged to write prescriptions for, however much we wanted, large numbers of narcotics. Certainly that led to addiction. Studies show that if you continue to use opioids after 4 or 5 days, that you probably will continue to use opioids. And you can see on this graph here how that the slope increases after that mark. So in the past few years, of course, the pendulum has swung right back, right? And we figured out that there is an opioid problem in America. And now the government, thankfully, is de-emphasizing pain ratings and is focused on our opioid problem. And after 2 decades, physicians are again encouraged to use our discretion in prescribing opioids to patients. Additionally, federal and state guidelines were created to help support physicians in that practice. And so these guidelines actually state that patients with an acute trauma should be given 3 or 5 days worth of opioids and not 30 days of opioids. And so this is also, of course, helping to curb the opioid problem. So in the old days, I used to get out my prescription pad, and actually we used to have a stamper, right? And so we get our prescription pad, stamp it, and just sign it, fill in the quantity, done. Well, it's not so easy now. So when the government created the guidelines, they also changed how we prescribe opioids. So I'm going to walk you through that really quick. Actually, it's not really quick because it's just not quick at all. So at the bedside, of course, I need to determine if opioids are indicated, right? And then I need to perform a risk assessment on that patient to determine if there's any history of prior substance addiction, and have a talk with the patient that does have a prior history of addiction. I need to obtain verbal and written consent. And then I go back to my computer because prescriptions now have to be electronically sent for controlled substances. So go back to the computer and open up the patient's chart and toggle to this screen. And on this screen, I need to click on View Report. And then that opens up the Arizona Controlled Substance Prescription Monitoring Program database, which is a central database that lists all of the opioid prescriptions for a singular patient. So you can see this patient had 27 prescriptions. You can see, the number of narcotic prescriptions. You can see the dates. You can see the quantity. So it's a lot of information for the provider. It also helps me as the ER provider figure out if there is one person providing opioids for a patient or numerous providers, if someone's doctor shopping, looking for opioids. So after I review that screen, I come back to here and I have to click Mark as reviewed. From there, this alert pops up that I need to get consent. So click accept. From there, another screen opens and I need to click up here that I did a risk assessment. I then need to click that I will obtain that consent, that the nurse needs to go ahead and have the patient sign, and that I reviewed the prescription monitoring database. All right, we're on step 10. All right, are you with me still? So from there, I need to sign that I'm getting consent. I haven't even signed for the prescription yet. From there, I have to put my finger on a fingerprint reader so it knows my identity. Then it pings my phone and I have to get on my cell phone and approve that it's actually me that's trying to prescribe a narcotic. So click approve on my phone. And that's a screenshot on my phone. From there, finally, the prescription pops up, right? And so I have to click there and then I have to click sign when it pops up. So that was 14 steps, more or less. So that's not easy, right? That took a while. So it's really not easy to prescribe opioids. So when you're thinking about an opioid problem, rest assured, we are not willy-nilly prescribing opioids in the emergency department or really anywhere. Yeah. No. Are you talking about the Arizona Controlled Substance Prescription Monitoring Program? Yeah. So no, the Arizona database does share information with some surrounding states, but it is limited to just Arizona and surrounding states. Yeah. Okay, so when we talk about opioid substance use disorder, we're talking about treatment with potentially 3 different medications. We're talking about methadone, buprenorphine, and naloxone. So a few methadone numbers for you. Methadone is a long-acting opioid agonist to treat chronic pain. Federal and state guidelines mandate that we don't supply replacement methadone doses in the emergency department unless there are extenuating circumstances. And I'm proud to say that, we do a pretty good job of not providing those replacement doses. Typically, it's someone who has been stranded due to a snowstorm or their car broke down or something, that we're providing that prescription. And we do have the Flagstaff Methadone Clinic that is, treating all of these patients. When we're talking about medication-assisted treatment, MAT, we're talking about buprenorphine. You'll also hear Suboxone being used. Okay, and Suboxone is a combination of buprenorphine and naloxone. Buprenorphine is a partial opioid agonist, which binds to the same receptors as opioids, but doesn't produce the same high. So it's really good at treating heroin, oxycodone, and fentanyl addictions. It really reduces drug cravings and those physical withdrawal symptoms. So in 2022 and prior, you had to get an X waiver and do special training and obtain a waiver through the DEA in order to provide and prescribe buprenorphine. With the Consolidated Appropriations Act in 2023, that made it so you didn't need that X waiver any longer, which really increased the number of providers that could provide buprenorphine. And we do have local MAT providers here in Flagstaff. When we're talking about MAT, we're talking about 3 phases. So we're talking about induction and that first dose when a patient's in moderate withdrawal. That requires really close contact with the care team over that first 1 to 3 days to stabilize that patient. MAT is really more than just a prescription. Then stabilization for that patient, finding the right dose, and then a maintenance program for that patient. We cannot assure next day treatment or follow-up for our patients in the emergency department. And so we are currently not prescribing buprenorphine from the emergency department. We do, however, have a naloxone distribution program. This was long overdue, but finally implemented in January of 2024, which is wonderful. So Flagstaff Medical Center and the Coconino County Health Department partnered. And every patient is screened and triaged by the triage nurse for opioids. If you screen positive, then you are offered a free naloxone kit, which is nasal spray, not injectable, so more likely to use, hopefully. Unfortunately, we've only had 6 takers to date. Only 6 people wanted the free naloxone, which is really surprising, but those are the numbers. The nurses administer the drug abuse screening tool, the DAST-10, which takes about 8 minutes to administer, and there are 10 questions on the DAST-10. And so at the end of the DAST-10, the patient is scored if they answered yes to any one of these questions or no to this question. And then the scoring helps determine the severity level for the patient. A DAST-10 score of 6 or more triggers an alert to the Coconino County Health Department Opioid Response Case Manager, and that patient will receive phone call, email, or in-person visit within the next 1 to 2 days. That is, if they've given us their correct phone number, address, and demographic data. That's often a barrier to care for patients. The nurses do. Okay. It's yep. Just an ER nurse. Yep, it's an ER nurse. Yeah. Thankfully, all of this functions without the physicians. The physicians don't need to order it. They, we aren't the ones doing it. It happens without us, being involved. So, honestly, more seamlessly that way. So the future of this program looks very bright. We're going to take checking into the emergency department out of the process. We've been approved for a vending machine. And so we hope to soon have a vending machine in our waiting room. So patients can just come to the ER to get, a naloxone kit without having to check in. Yeah. Wait, he's running, wait. She's pretty loud. It's not. So I believe your question, if I'm hearing you correctly, is the screening only for opioids, or is the screening being done for methamphetamines as well?
I'm wondering if people who are reporting other drug use or screening for other drugs, if they're also being offered naloxone, given the chances that those people will also be using opiates in the future is really high.
Sure. So right now, if they're screening positive for opioids, then they're offered the naloxone. Our nurses have a very low threshold for offering anyone the free naloxone kit. So, I mean, if the patient wants one, we will give them one. And so thank you for teeing me up for the next slide. So we'll talk briefly about methamphetamines and stimulants. Thankfully, meth is not even quite the problem that opioids is in Flagstaff. Meth is actually a bigger problem down at our Cottonwood facility. But in Flagstaff, we had 90 visits by 80 patients in the 2023 calendar year. So really not a very large volume at all. Thankfully, Spectrum Services in Cottonwood does assist us with our patients that are on meth and looking for help. But you know, we don't have local medically assisted detox, intensive outpatient treatment programs, or rapid placement into rehab. A lot of our meth patients come to the emergency department, you know, on meth, intoxicated with meth, and the treatment for them is, you know, much the same as it is for alcohol. It's just time and monitoring, and there's just not much else to offer these patients. Very often our patients get frustrated that, you know, quote unquote, nothing is happening. And sometimes they get up and they leave. But the patients that are willing to stay, we do offer behavioral health, social work consultation. Our meth patients are some of our scarier patients in terms of the threat of violence. And so I asked our a security detail at Flagstaff Medical Center to pull the numbers. In calendar year 2023, we had 214 workplace violence events at Flagstaff Medical Center. And then I broke that down, or he broke that down for me. In February of 2024, there were 15 events, 13 cases of disorderly conduct, and 2 assaults. So 9 of those patients were intoxicated. 2 were behavioral health patients. 1 patient was seeking pain medications. And then just out of interest, actually 0 of those patients were in law enforcement custody. So part of the ask in having me talk with you today was about ideas for future. So the next few slides are about my ideas, you know, for future. I would love to see expert for all ED trauma patients that use a substance prior to arrival, not just our trauma patients that are admitted. I feel like that's a real teachable moment for, you know, for patients coming in that have just, you know, totaled their car or sustained some other trauma, but we just don't have the resources for that currently. I would love to see substance use disorder counseling services in the emergency department for our boarded patients. But again, you know, we don't have the resources available for that. A local sobering center and transportation to that facility would really be ideal for our intoxicated patients. Local medically assisted detox with services for both adolescents and adults would be ideal. Local intensive outpatient treatment programs to place emergency department patients into immediately. And same-day access to outpatient rehab services, again, ideally from the emergency department. All of this keeping in mind, of course, that we've got this nasty insurance problem to deal with as well. as we're talking about barriers, to getting patients to where they need to be. When we're talking about getting patients into counseling, we really could use not just counselors, but counselors with some substance use disorder training. And again, hopefully next day appointments. I know I'm asking for a lot, but I'm an ER doc, so I'm going to ask for it, right? So, of course, the preference by patients would be to have a counselor that they really can identify with, a counselor that is the same gender, a counselor that is the same race and ethnicity as them. Because there's a real reluctance to share personal information if you really don't identify with someone and connect with them. There's a lot of opportunity in education, a lot of high school outreach that can be done on the reservation and locally here in Flagstaff, including the Kinlani dorm. For those of you that aren't aware, the Kinlani dorm is a place where students from the reservation can live and attend Flagstaff High School. Thankfully, the Kinlani dorm has a Native American counselor and licensed school psychologist available who treats mental health needs and can partner. As we're talking about education, I would love to see that expanded, of course, to addiction medicine rotations for nursing students, for medical students, for residents. And certainly, we can make big inroads into the future, if we can accomplish that as well. I would love to see medically assisted treatment in the emergency department. Many emergency departments across the country do have MAT programs in the ED. So if we can bridge the gap between the emergency department and outpatient services, we can talk about starting a program like that. But we've got to have that next day follow-up, same or next day follow-up for those patients, or else it will fail. And then needle exchange program, as I was researching, local services for this presentation, I couldn't find a needle exchange program or anyone that knew of one locally here in Flagstaff. Does anyone, I was hoping to actually bring the answer back. So it looks like there is one that I'm just not aware of. Is there?
Sonora Prevention Works.
Okay.
Provides the, excuse me, I'm sorry. Sonora Prevention Works has a local harm reduction program. And I'm actually with Community Assistance Teams of Flagstaff, and we work with Sonora Prevention Works. And we also provide needles as well as naloxone kits anonymously for free off the our mobile outreach bus. So it is, but as I'm listening to you, actually, there's a lot more I want to talk to you about. And I'm going to be up on this panel, so hopefully I'll get that opportunity. But there's also VEN, which is they focus on Hep C reduction, or hepatitis actually, and HIV reduction. So they also offer harm reduction materials on the streets. So I will hopefully get the opportunity to say some of those things when I'm doing the panel, and would love to talk to you more about those.
Wonderful. I would love to leave with that information today to bring back to our BH workers. Yeah.
Anybody else?
I was waiting for you to talk about fentanyl test strip availability.
Nope, I don't have that up right now.
Hope put that on your want list. I think they can put it in your vending machine.
Wouldn't that be nice?
Yeah, they have it at the county health department.
Uh-huh.
On my want is the same as yours, the medically assisted treatment. And now with the dropping of the data waiver requirements, pretty much the standard of care for most inductions are in-home inductions. And it's not often that we actually do next day follow-ups, even with those. And so I recognize deeply that you don't have the personnel for this and the time, but that is something that is becoming much more easily readily available and accepted in the medical community as a no wrong door policy. So people leaving EDs, jails, prisons, the prison is more the long-acting naloxone injections, but in terms of buprenorphine, that is something I'm hoping we can start nudging you guys towards not being afraid of. And then I'm just curious about, is there any move about outpatient alcohol detox with non-controlled substances like gabapentin, or supplying patients with non-controlled substance outpatient methods for alcohol detox?
Specifically,
Just, if they have a history of DTs and they are concerned that they are going to go into withdrawal, and I'm stunned that we don't have a place in flight staff.
so you're asking what we do in those instances?
Yeah.
Yeah. So when someone comes in and they are in the early stages of withdrawal, we help to stabilize them in the emergency department, typically with benzodiazepines. Ativan is typically used because Librium is a little longer acting. Then we get behavioral health involved, and we ask our intake workers to come down and find support for this person. So we need to get a family member, a friend, someone to be with them, to help monitor them as they start towards sobriety, right? Because what we don't want to do is we don't want to discharge that patient from the emergency department with the prescription in hand all by themselves, because that will surely fail. And so my method of practice is to sit down with both the person who's withdrawing and their loved one, their friend who's going to help them out. And I typically hand the prescription to their loved one or the person that's going to help them out and say, okay, I want you to help them, but they're not allowed to take this medication if they've been drinking, and you are going to be the monitor to make sure that they haven't been drinking. So we do prescribe benzodiazepines from the emergency department for our alcohol patients. Yep. And then with regards to Matt, we have a real problem with follow-up from the emergency department. We just don't have local primary care provider access here in Flagstaff. We have a shortage of primary care providers. You all, when you try to access your PCP when you're ill, you call in and the hope is that they can get you in same day or next day. But, typically the next appointment is, not for a week or a couple of weeks at least. We can't work any magic in the emergency department, and we don't have a back door or an in with any of these clinics. And so when we discharge a patient, we feel like we're discharging them to the wind, that hopefully they'll call and hopefully they'll, manage to get an appointment. If we have a social worker on at that point in time, we do engage the social worker to try and arrange a primary care appointment for them. But our social workers also can't, work magic and, make an appointment appear out of thin air either. So, that gap is, really our problem in the emergency department. Actually, that gap is our problem in the emergency department. So anyway, that was the end. And I open it up for more questions. That was in Banff. Yeah, yep, Lake Louise.
All right. There we go. So this is less of a question, more of an observation, maybe a question, but for everybody. You are aware, I hope everybody's aware, that we used to have from around 1977 till about 1987, we had a LARC,
local alcohol reception center, which was defunded based upon, I'm going to say, racism. But it was defunded because the city didn't want to fund it because the city blamed the Navajo Nation for being the problem. And the Navajo Nation said that it was a Flagstaff problem. And there's some real racism that went on in that defunding. But we did have a LARC during that period of time. Part of the issue with the LARC was that it was deemed to be ineffective because it was quote unquote viewed as being a part of the revolving door. However, I have been pushing for a reinstatement of that program. So I'm with you, Jen, on that. The other is that you obviously also know that we had a medical detox center associated with the guidance center that lasted, I don't know how long it lasted, to be honest. Initially, it was set up to be a 3-day program. It then got shortened, and then it got shortened more. And now I don't know that it exists at all.
The intake triage unit?
It was
ITU.
actually initially called a detox unit. Yeah, initially it was a detox unit. I mean, when it initially started, I was part of the conversation that got it started. So yeah, it's sad that we had these things and now we've fallen back because they weren't observed. There was an assumption that we could cure a problem with these. And so because we didn't cure a problem, they got essentially defunded, and so we don't have them anymore. So yeah, I'm glad to see you're pushing for that. I really would like to talk to you more about that. So anyway, that's kind of one of the millions of comments I'd like to make, or two. I'm sorry, two.
Thank you.
I just wanted to ask, it seems like a real intervention point for alcohol, which is what we're currently focused on in our work at the health department with the Hope Coconino Coalition. But an intervention point that we noticed in your presentation is in the ED with those clients who are coming and sobering up there, maybe peer supports. And so I'm wondering if you've considered having peer supports there. It doesn't necessarily take licensed counselors to connect with those people and get them into treatment, but having someone who's been there, is in recovery currently, that can talk to people and help move them along that process through those stages of change and considering, doing something different in the future.
Certainly that's a consideration. As we're talking about credentialing providers and having extra people in the emergency department, I mean, that would have to fall under behavioral health services, I think. But I would love to see, more peer support for people. I think that is such an opportunity and a missed opportunity, especially for our car accident patients. If we can't do expert, maybe we can have a peer counselor come in and talk with them about making a change for the future.
I had a question about your take-home naloxone program. So you said 6 patients accept the naloxone. I'm curious if you have thought about why so few patients are uptaking it and if it's related to community level stigma about taking home naloxone. And maybe this is also a question for the panelists that come on later too about just what are some harm reduction techniques that might be happening both in the community, but then also in the ED as people are being offered this program with the naloxone. I'm just curious about your thoughts on that.
I think it's a really interesting question. We were very surprised by how few people took us up on the offer. In part, it's probably reflective of the total number of users here in Flagstaff. By the numbers, we don't have that many, but certainly I thought it would be higher than 6, so I think that's something that we need to look at for future and try to figure out, is there something different that we need to be doing with regards to the screening? Is there a different way that we need to be asking the questions? and go from there.
Yeah, just related to that, could it be in terms of not understanding how to administer it? Because I think there's a process, I've watched training videos and things, but is that education provided when it's being offered?
So the nurses do talk with the patient as well as the family members or friends that are with the patient and inform them that, it's nasal spray. It's not, injection, because a lot of people are worried about giving an injection. A lot of people are worried about causing harm by giving naloxone. And so our nurses do educate, about what you will see if you do give naloxone to a person. So we are doing that education. Yeah. Yeah.
Would it be feasible or possible to like potentially adopt like a opt-out model with the Narcan instead of like asking clients if they want it, saying it's our standard protocol if you've come to the hospital, like emergency department, to leave with naloxone. If you like want to opt out, you can, but that way it sets more people up to leave with it.
I think that's a great idea. Yeah. Yeah. I think that's a great idea. Yeah.
I come from the Hopi Reservation, and we've been able to do outreach campaigns and do at least our 40-minute training on how to administer Narcan. And so we've been able to give out over probably up to 200 kits within our community. So that might be a way to do community outreach. And I think it's important to educate community members on how to administer the Narcan, because that can be intimidating to individuals.
Certainly. Where do you distribute from? Is that from the Hopi Emergency Department?
No, we go out into the community, or we get our kits from the county, as far as Navajo County. So that's where we get our kits from.
Okay.
So we do, I was looking at your questionnaire and I'm wondering if the stigma or the questionnaire itself is an impediment to giving out the kits. We have given out during that same period of time way more kits than you have at the emergency room. And I can actually get you, I think, from Sonoran Prevention Works, how many kits they've given out during that same period of time. We basically do it. There's no questions asked. It is free for whoever wants it or whoever feels the need for it. And, the instructions are there. Most people who are familiar with the street use actually know how to use the kit anyway. And so I don't know, I was just looking at it going, I wonder if the questionnaire itself might be intimidating or off-putting, or if there might be a stigma, embarrassment, just even having to answer those questions. So I don't know, I think with having a vending machine kind of concept might actually improve your the rate of providing those kits.
Yeah, I think that's something to consider for future. The DAS-10 was meant to try to capture patients that could then receive follow-up from services from the health department. And I am not sure, because it's a nurse-driven program, if the patients are offered the naloxone before the DAS-10 is administered, meaning they screen positive, yes, and then it's offered, and then the nurses go on to do the DAS-10 to determine the severity of the use.
One more, sure.
keeping you all from dinner.
I'm sorry, I'll try to be really fast. I just we had this talk in our Echo about fentanyl, and the DEA's seizure of pills, 7 out of 10 of the pills seized had a lethal dose of fentanyl, and the lethal dose of fentanyl can fit on the top of a very sharp pencil. And so, and several of my pregnant women who had claimed that they did not know that there was fentanyl in what substance they were using and became addicted to the fentanyl, which is further support for the kind of no wrong door model of, can we just blanket the world with Narcan? and rather than even wait till they have a positive test, but to just say, it is out there, it's everywhere. You may not be aware. Yeah.
With that, I'm really excited for this panel coming up soon. Dinner is ready. We will convene, but thank you, Jen, for the presentation and for Leonard. I think I'm excited to hear some of the connections. A lot of this was trying to make connections and help folks work together to solve, really, as Wendy had described when we met a while ago. It's kind of, I'm going to call it, I shouldn't say it, almost an unsolvable problem, but we're seeing a lot of solutions here. So thank you all, excited for this. We'll see you back here in about 45 minutes. Folks, we're fortunate today to have a tremendous panel. They will do their own introductions here shortly, but I'd like to introduce Holly Figueroa. Holly, she serves as a tribal liaison with Blue Cross Blue Shield Arizona Health Choice. And as tribal liaison, she's been working to strengthen tribal relationships with the 17 tribes in the Health Choice service area. So I will let you do your introduction, but we're fortunate to have you here to moderate this panel. Thank you so much for all you do, and I'm going to turn it on over to you.
Are we all here? We're all here? Excellent. All right. Oya skwali. Umaya sayakam itamam yaftofalte. Ne Holly Figueroa Bahan Matiwa. Ne Tala Manam Hopi Matiwa. Ne Tawangwa. Ne Sepalang Aksino. Ne Navatuk Ovi Mkita. Good evening, everyone, and welcome. My name is Holly Figueroa. I'm the tribal liaison for Blue Cross Blue Shield Arizona Health Choice. I come from the Hopi and Oke-Awinge people in northeast Arizona, so about an hour and a half from here. And then Oke-Awinge is one of the 12 northern pueblos in New Mexico, and serving as a tribal liaison for Blue Cross Blue Shield Arizona Health Choice. I'm from the Sun Clan. I come from the village of Sipalavi, which is on one of the 3 mesas across Hopi land. And I live here at Navatuk Ovi, which is the San Francisco Peak. So living here now for about, oh gosh, I think 24 years. I actually moved here from Shepherd Air Force Base. I am an Air Force brat, I guess you could say. I grew up in the military all my life. I was born in North Carolina or South Carolina, and didn't know what civilian life was like until I moved here to Flagstaff. So multiple culture shocks for me, living off of a military base, but also kind of trying to reintegrate into my village and learn the culture, the language, experience some of the things that some of our relatives experience off reservation in cities and towns, and they weren't always the best experiences. So definitely culture shock on multiple levels. But I've been here in Flagstaff and worked a couple different places. I started out at the county and knew a lot of people through the county. And then I actually took some time off, and I was thankful to work for NARBA. So I'm one of the original NARBA folks that started and have since gone through many transitions. I'm a lot of times the joke amongst some of our tribal partners as to what my email address is this year. So it's definitely been a journey. I'm really thankful for the work that I do and that my leadership is supportive of the tribal work that Health Choice does in Northern and Central Arizona. And thank you so much for the opportunity to serve as the moderator for this evening's conversation. I was listening earlier and heard from some of the participants that there have been good conversations thus far. And so hopefully that will continue onto this evening. And so very thankful for our panelists also for joining us this evening. So I'm going to actually ask each of you to take a couple of minutes and do a self-introduction, if you wouldn't mind. So I'm actually going to start to my immediate right here. Hi. It's on.
Okay, sorry. Hi, my name is Kelly Gonzalez. I am the residential treatment program manager for the Guidance Center. I am a recent move in to Flagstaff. I've been here for about 2 years and fell in love with the scenery. I'm originally from Alaska, and so it's very, similar to that. Really what I love about this community and being here is mental health is obviously my passion, and watching community facilities with their outreach and bridging those gaps and finding new ways to, get the best care to the members that we serve is really something that I think is really special about Flagstaff. So thank you.
Thank you, Kelly. I actually lived in Alaska as well. Yay. Excellent. Great. Thank you. Tatum.
Hi, everyone. My name is Tatum Covey, and I am an outpatient social worker for Northern Arizona Healthcare. I am one of two. I have been in Flagstaff for about 12 years now. I'm originally from Phoenix, but I claim that, so don't put that on me. I'm local. And I've been in nonprofits for about 8 years now in town. And what that has looked like for me has been in domestic violence services and crisis response services. With nonprofit housing has been a good chunk of my time. And so I am a big proponent of housing first. And so if that's a concept that you aren't familiar with, highly, highly recommend you look into that. And I have also been around a lot. I was the director for Northern Arizona's cancer support community. So I had some time in direct care with people who are surviving with cancer, navigating cancer, and now I'm with Northern Arizona Healthcare. And so my position there is working with folks in their homes outside of the hospital, really around social determinants of health. So all those things that affect your healthcare, affect you getting the healthcare you need, I help with. And so it's really trying to create as few barriers as possible for our community members here in Coconino County, as well as Verde Valley. I think that's most of my things. Oh, I'm also involved in the local housing authority here. And so I just highly, highly encourage that if you are passionate about housing and or social determinants of health and or really providing care to our community members, that you get involved at a local level, especially in our government, to make those changes happen, like funding.
Thank you.
Hi, my name is Corey Runge, and I kind of was born into social work quasi thing. My mother ran domestic violence shelters, and I was constantly in and around them as a child. I also grew up in a house with mental illness. And so I learned about many of these things through close connections with family. I then went in the Marine Corps, became a veteran, which I realized now gets me tons of social cred with making rapport with people and stuff like that that have been through a lot of trauma and traumatic experiences that way. I became a law enforcement officer and worked in law enforcement for about 20 years, 24 years, counting my time working in jails. I've worked for county, I've worked for NAU, I've worked at the city of Flagstaff for many law enforcement areas. I ran their crisis intervention programs for about 10 years. In CIT, I teach mental health first aid, many of those types of things. I also went to school, got my bachelor's in psychology, got a master's in applied sociology. So I am multidisciplinary. I mean, everything I do is like the surface of a lot of different areas, right? And what I do is I try to work for different institutions, and I hoard like Golem does the ring, titles, certifications. Like I'm still a certified police officer. I still am a reserve police officer with flag, which gives me access to their records. It gives me access to their staff. It gives me access to those kinds of authorities. I also currently work for the NARBA Institute, running their housing programs for permanent supportive housing. And we also are affiliated with the Guidance Center. That gives me access to many things. So I can put on different hats depending on the situation, and gives me access to so many records and ability, which I may not be able to share, but generally I can give advice on what I would do if I was in your situation. And so there's a lot of ways that we can work. I don't even know how to define my job. It's so crazy, right? But it's one of those places that I just kind of put myself in the middle of everything, and it allows people to collaborate with me.
Good afternoon. My name is Wendy White, and the hats that Corey doesn't have, I might have. So I have a background in anthropology, but I got a degree in English, my bachelor's. I went to law school. I'm actually still a practicing lawyer. I've been a criminal defense attorney in Flagstaff since 1986. I've also been a prosecutor in Flagstaff. In 2006, I co-founded Flagstaff Shelter Services. At the same time, or during that same period, I was also the criminal justice coordinator for Coconino County. Corey and I knew each other back then. I was instrumental in helping set up the crisis intervention team program. Also helped set up the mental health court in the city of Flagstaff back in 2006, 2007. I kind of took a sabbatical after running Flagstaff Shelter Services for about 4 years. It kind of drained me. So I tried to do some things that were fun. I'm a rock climber. I go rock climbing. That's what I do for fun. And then in 2019, I decided that I wanted to do more than just helping individuals in the criminal justice system. And I set up co-founded Southwest Center for Equal Justice. And we've been, we work on decriminalization of mental illness, decriminalization of behavioral health issues, as well as reducing racial disparities in the criminal justice system. More recently, in 2021, I co-founded with Daryl Marks, who's an Indigenous advocate, co-founded community assistance teams of Flagstaff. And that is what I am doing in my current iteration of my life. We are doing mobile outreach on the streets of Flagstaff to people who are unsheltered. And we work with a lot of people, many people who are chronically unsheltered and also have serious mental illness as well as behavioral health issues. Our goal is to collaborate with as many different agencies as possible, with many different people as possible, to help respond to the issues. And this is what I think Stephen was saying earlier, is that at some level I stopped talking about things creating a solution, as opposed it's like, let's create humane responses, as opposed to setting ourselves up for failure and disappointment by saying we're going to solve these problems. What we can do, I believe, is to respond to problems in a humane way and reduce the issues as well as possible, but a solution that might be hard on some of the issues that we're dealing with. Hopefully we'll have some more conversation here momentarily. Chris.
Oh, yeah, Shay, Christy Bunchia, Nanis Technista, Kabam Basachin, Kilichini Desiche, Hanali Desnella Kutaya Dinensla. I'm originally from Ganado, Arizona. I lived in Flagstaff for approximately 2.5 years now. And I was explaining to some people that I lived up in Utah for the past 20 years before moving down here. So it's great to be here. So I'm the newly appointed CEO for Native Americans for Community Action. It's been for 1.5 months now. So it's a great experience. It's great to be here. I learned a lot about this community. So I also want to recognize my wife here, Mary, and also my daughter here, Seneca. So we come as a collective as well. So. But yes, gosh, so much to talk about. I graduated from University of Phoenix. I got my master's degree back in 2013. So I've been practicing for approximately 14, 15 years as a psychotherapist. I'm a licensed clinical mental health counselor and also a licensed professional counselor in Arizona and also in Utah. So my background is trauma. So that's what I wish to bring. I wish to teach a little bit more with our leadership here at NACA. As we're working with people with at-risk youth, people with developmental disabilities, unsheltered relatives. So it's really cool to be here and learn more about our community members here. I hope to network and build our community so we can give back in a way that's good for our people. So yes, so thank you.
Oh yes, Wale, thank you. Thank you all for being here. And I think each one of you has touched on a topic that or sitting in a position or a role that is going to be instrumental to the conversations that we're going to have. And so we're really looking for this particular discussion this evening to focus in on some of the cultural aspects of what we're going to talk about in terms of crisis management as it relates to our substance use disorder populations here in Northern Arizona. And in my role, I've been able to work with many tribal communities on developing crisis protocols for their communities, and really the work that has gone into that with some of my colleagues that are here in the room can tell you are not cookie cutter. The coordination that it takes to get an individual out of the Grand Canyon, the agreements that it takes to even enter onto the land to be respectful of tribal sovereignty, the coordination, collaboration with the different tribal health program staff people and the county and the city and our healthcare systems, the IHS healthcare system, the VA system, the 638 healthcare systems. And in my experience, working to address crisis, working to help prevent crisis, making sure that our tribal members are able to live and be on a good health and wellness journey for centuries and generations to come is really something that is very meaningful to me, is very important to me, and I'm very passionate about. It's very scary when we talk about culture, and culture can be a very sensitive topic as well. To the very existence of our people, just having the language, those cultural values that each of us bring to the table, to every interaction that we have with one another, really affects the way we as human beings take care of ourselves, how we think about health and healthcare. What are some of the consequences that we believe we're experiencing because of something that has happened with ourselves or in our families or in our community, even COVID. You heard a lot from communities, tribal communities, indigenous communities, that this was foretold. And so there's so much to go along with culture. And I think we're gonna talk about that this evening. In my experiences, being a mental health first aid trainer, is also something that's really important. And I was so excited to see that there is an Indigenous curriculum now. So that's something that I know my agency organization and myself are constantly out there promoting, because we need to have these conversations with our communities. A lot of times, those of us that are in the system, we understand our conversations, we understand our acronyms, we understand our jargon, but community, our elders, the kids nowadays, they're having their own conversations, and they need to understand the impact that the things that we're talking about and experiencing, these crises that are happening, are going to affect them and their communities and their families. So I'm really, really excited about this conversation. We're going to talk a lot about, resources, collaboration. What does it mean to be culturally responsive? What does cultural humility look like? So I'm going to start asking questions, and I don't know if you all had access to these questions or not. Okay, good. So we'll talk about a lot of these different things. There's so many things. I know that I'm working right now with the Coconino County Justice Coordinating Council, CJCC, another acronym, and really looking at the tribal experience within the justice system. So there's so much interaction and intersection in the healthcare system and the justice system and community. So I'm really looking, hopefully we can all walk away with something we didn't know before, a new resource, a new partner. And this is just the beginning of those conversations, because I can tell you, I've worked for the county and I've been part of CJCC for a long, long time. And I went away and now I came back and the conversations are still the same. We're still having the same conversation. So how can we move forward? And hopefully that's what we'll begin today. So again, I'm going to start asking questions, and in no particular order. If someone's just dying to answer their question, please feel free. We have a mic. If you have questions as well or comments, please feel free, because we're all here to learn with one another. We all have had experiences, I'm sure. And so that's going to be how we're going to learn as well. So my first question is going to be, what does culturally responsive care mean to you? What does culturally responsive care mean to you? Anyone? Kelly.
Culturally responsive care to me means being respectful of, the community that we serve. At the Guidance Center, a large one of my populations, right, is these surrounding nations that surround Flagstaff, and really understanding or attempting to understand and empathize with where they're coming from, with their homes, traditions, their different cultures. So we do things like Monday, we have an eclipse happening, right? And so being culturally responsive to that, we've made arrangements to where my Native American members can observe that in a cultural way, and really talking to them about what their needs are from us, right? Because we can't get better if that conversation isn't happening and we don't get that feedback. So it's definitely something that that needs to be at the forefront of the services that we're providing, because I think that it is definitely a huge miss that's happening just with our services, really decolonizing what our therapy looks like to the people that we serve.
Thank you.
Wow, great question. Piece of conversation I love to have, continue conversation. With NACA, we're very unique, I think, from different organizations. At NACA, we have 8 master's level therapists, robust therapists, very intelligent. 4 of those individuals are Native American. And, as a clinician as well, the approach we take when treating people is more of a collective. We're treating not just the individual, but we're treating the family. In a sense, we're also treating the community as well. Sometimes, treatment does look like, we take on the spiritual realm of things. We're also implementing traditional, spiritual goals that they can work on. So in a collective sense, in a culturally responsive, we're treating not just the individual, but basically just the whole family there. So I think we're very unique in that manner. Activities, things that we do with talking circles are all traditionally Native centric. So yes, decolonizing treatment. I love how you address that. It's something NACA is really, we're taking a lot of pride in it. We have a lot of honor in doing that and within that process as well.
So I teach cultural awareness for white lawyers because most lawyers are white. And honestly, 88% of all of the lawyers and judges in the United States are white. very sad, but that is true. And what I try to do, I kind of come at it from a bit of an anthropological perspective. But what I try to get people to be aware of is that to be culturally aware, you have to be aware of your own cultural. You have to be aware of your own assumptions. And if you once you become aware of your own assumptions, then you can be open to other people's culture. But if you simply say, hey, my culture does this, hey, I'm a, well, actually, this is a joke. I have to say this joke. I always say it. I grew up in Vermont, and some of you will not get this joke. I grew up in Vermont in a little town, and which is an oxymoron. But anyway, a small town in Vermont, and my town was so white that the mascot for our high school football team was the wasp. Some of you get that, some of you don't. This is true, okay? So the point being, yeah, it's like, I'm a wasp. I grew up in New England, and in order to be open to other people's cultures, I have to understand what that means. What does that mean? What are the assumptions that I make? And then I assume everybody else operates in the same way I operate. They think the same way I think. Well, you need to set that aside. In order to be open to other cultures, you need to set it. It doesn't matter whether you're a WASP, whether you're Native American, whether you're African American, whether you're Korean, whether you're Asian, whether you're African. You grew up in a culture. It permeates everything about you. And in order to be open to other cultures, you have to recognize your own culture. Once you can do that, then you can start setting aside those cultural assumptions and creating true connections.
One of the ways that I work through this is I'm a human. We're all humans, and all of us have our strengths and our differences, in which we can value those strengths and those differences. And honestly, most of life I fumble through. I make mistakes, I trip up, I got to apologize a whole lot based on my ignorance, because there's so many things I think that I know that, and I don't know much at all when you think of all the things there are to know. And so I tend to work on assumptions, and then I find I make a mistake and I apologize and try to accept that and try to move forward and try to hope that I get grace for my cultural assumptions, while trying to respect and value all humans from the different parts of their personalities, the places that they come from, and carry forward with what we can do, because I just don't know what else to do. Oftentimes is just, other than just value other humans for who they are, where they come from, for their strengths, for their weaknesses, and just truly love and care about people.
I think from my perspective as a healthcare professional adjacent, is that in healthcare, we tend to look at like, there's a problem that needs to be solved and how do we solve that? And so as a social worker in that field, like I have a harder time like looking at the problem, being like, that's how you have to treat it. That's the best practice. And Western medicine isn't always the right thing. And so I think it's being aware that the patient is really the professional in that situation of like their own lives. And like we can provide as much education as possible, so that way people have the ability to make the choice of what's best for them, but being aware that just because in a medical facility that this is the specific recommended treatment doesn't necessarily mean that it's the right treatment for that human. And I think it's also really, really important to recognize the history that comes with like being culturally competent, of like there is a long history of prejudice and people having to navigate being hurt by our respective fields, and knowing that that trauma continues to this day and continues to impact people, and that's not absolved. And so that influences how people react within the system, and having that compassion and care for folks individually is just so important. So that way that person knows that they really are the master in how they choose to navigate this world.
Excellent. Thank you for your responses. And just reflecting on some of your feedback and comments, I love the word love, right? We're all human beings. We all have emotions, and also the history. Understanding the history of the people that we're serving, that cultural humility piece is really something that I know in the work that I do, really focusing on understanding what cultural humility is and how do we practice that? How do we know and tell ourselves we're not know-it-alls. We are not the know-it-all of everything. I don't know everything. I don't know everything about being a tribal liaison. I don't know everything about being a mother or a sister or auntie. We learn every single day. We learn from one another. I probably will learn something on the day that I die. And so being able to recognize that about myself, regardless of the title or the letters behind my name, I'm still a human being at the end of the day, and the people that I'm serving are human beings. And how do we incorporate that in the work that we do? In the healthcare system, I think you touched on that, Tatum, very much. Everything that you all are saying is beautiful, but how do we see that take action in our systems, in the hospital, in the Flagstaff shelter, at the guidance center, in the police department? How do we see that cultural humility take action? You know, how do we teach our leaders, you know, the decision makers, that these are the things that we're seeing boots on the ground? We are seeing these things, and believe me, I understand, you know, a lot of times our populations here in Flagstaff, and we'll be very open and clear, we are a hub. We are a hub for a lot of our tribal communities. We are a hub for people going from California to Texas, wherever they're going. And a lot of people love Flagstaff. We're very fortunate to live in such a beautiful place, to have the Grand Canyon, to have rich culture here in our communities. And so that attracts people, and people want to stay here, and it's a beautiful place. But along with that, you know, there can come some of that tragedy. And so that being said, how do we kind of help our agencies, organizations, communities prepare for some of these crisis type situations? And probably a lot of us know that crisis isn't just, you know, a mental health crisis. There could be a natural disaster. There could be someone becomes unsheltered. And all of these things mean different things to everyone. So I think that that's also part of, you know, how do we ensure that the way we are experiencing things, or the way we're talking about things, is what we're trying to see happen within our systems and organizations. So that being said, when we're thinking about culturally responsive care and cultural humility, and, you know, training our white lawyers and our non-tribal relatives, how do we get to that place? How do we make sure that people that come to our healthcare systems, and this is, you know, all healthcare systems, whether it's the VA, whether it's IHS, whether it's NIH, you know, we have a lot of people that are transferring across the board. You know, we all know we're in a workforce crisis, right? We got people coming at us from all places. And so what are we doing to make sure that not only do those people who are coming to our cities and towns and communities, serving and taking care of our people, our communities, our relatives, how are we preparing them for that? How are we educating them about some of the things that are happening in our community? Who are the people that live here? What is the history that has been experienced, and how does that impact our community today? Whether it's historical trauma, whether it's, you know, the opioid crisis that we're in, and how does that impact Flagstaff and the surrounding communities? So that being said, I'm hoping that you're thinking in your mind, you know, culture, crisis, healthcare, preparation, prevention, intervention. Who are the collaborators? Who are the partners that you know of, or that are partners of your organizations that you reach out to help in that service delivery, or in the preparation of that service delivery? Whether they're local, whether they're regional, whether they're national, or even tribal. Who are those partners? And we're hoping that we're taking notes, because I know I'm going to be, because I'm always looking for people to collaborate with in the work that we do, because we all, I think, are in that business of service delivery or program development. So I'm going to actually start with Tatum today, or right now, not today, and have you start us off, Tatum.
Yeah. I think something that I've learned kind of recently actually is that we really tend to silo, right? Like in our professions of like social workers, and even in social work, like medical professionals and behavioral health and substance use and opioid specific substance use. So we like silo within our specific areas, and that harms everyone in our community. That harms us, that harms our patients, that harms our clients. And so for us as professionals, I think it's our burden to take that on, is to have things like this where we collaborate and talk to other people and find out what other people are doing, because there's so many untapped resources here, especially in Flagstaff, that we're missing things. And so our people suffer. And so for us as professionals to bridge that gap, I think is paramount one. And really just keeping those conversations open of making changes. And like, when I was prepping for this and I was looking at who else is going to be on the panel, I was like, oh yeah, like Wendy's going to be here. Like she does the CATS bus. Like that's so fucking cool. And like, it's just so important to like know who your community members are and be vocal and be open about things. And so I think some of the resources that I find really, really helpful is one, the Continuum of Care is a meeting that happens every other month. And it's a lot of different providers that all come together and talk about what's going on in their agencies and what they need help with. And there's like some presentations so that people give like short little spiels about what's happening. And it's like a really quick way relatively of like, you're committing 2 hours every 2 months to learn about all these different agencies in town. And all of them are centered around helping, most of them around like housing or housing adjacent. And so there's a lot of folks at that table. And so taking opportunities like that to educate yourself, and that's open to the public too. You don't have to be part of an agency. Our Coconino County Community Services, the Health and Human Services Department, is a powerhouse of services. And even if you call there and you're like, I'm not really sure, like they'll point you in the right direction. And so it's also like keeping those channels open and asking those questions and making those connections with other people that I think really, really can be helpful.
Thank you.
Thank you. Yeah, to play off that, I collaborate with a lot of different stakeholders in town for a lot of different reasons. But first, usually people come to me because they have a problem, whether it's an individual or usually a small community group or something like that, in which they would have solved it themselves if they had all the answers. Or if their institution, they know the rules of their institution, they would have solved it themselves. So usually you do have to reach outside of yourself or your organization to handle this problem. So if it's an individual, I look at it, do they have food? Are they hungry? Do they have shelter? Are they cold? Are they wet? Or, do you meet those base human needs and then learn about them, more about them? Where do they come from? What is their culture? What do they like? What do they don't like? Do they have certain theological, inclinations, anything like that? And I have to know that to know the best direction of an appropriate resource, which has a likelihood of success. We talk so much about, histories of colonization or slavery or historical trauma based on boarding schools in our history or housing or all these different things that this person's history and their cultural heritage may have experienced along the way. And it's nice to have a broad perspective of those kind of, global issues in which you can say, hey, they may not like this other program because of the historical impact that it's had on them or their demographics of their plan. And so with that, working in different institutions with justice, with health, with all these different things and understanding their own theologies, such as health has a big thing about voluntariness. I mean, for some reason, they want people to be voluntary to get treatment. I don't get it, right? I come from justice. You don't like something they're doing, you make them do it, right? You arrest them, you force them in there, you do an involuntary commitment. That's what we do, right? And so I have to strengths, the benefits and the consequences of that institution, as well as the strengths, benefits, and consequences of the health and whether it's likely or not. Not everybody wants help. You know, and a lot of times I'm getting called in to talk about issues, not for the global overall group of homeless people. Most of them aren't dangerous or anything like that, but a small percentage of them do engage in violence, right? And Dr. Khan spoke about the violence that's happening in the ER and the assaults on nurse. It's a high number of people being assaulted at the guidance center at these things. It's not very many people doing the assaults. It's a very small number of people in these things. So you can't stigmatize the entire population demographic based on those few assaults, but you do have to respond. Otherwise, the caregivers, the people who are out there can't be safe. And if the employees don't feel safe to do their job, they can't be effective at it, right? And so you start thinking about what's there. Is this an individual with a potential of violence or stigma associated with it? Think about the likelihood of the system that you're looking at and the best resolution, and then start with the lowest, impact. Like maybe usually it's health, right? You encourage them to go, you encourage them. And if they won't do that, there's other progressive steps based on the institutions you're using that might be, because you're balancing society's interests also, right? We as individual citizens have a right to be able to walk around in our public and feel safe and be safe. And so if that's impacting somebody else's right, that's something we should take into consideration, right? And there is no one size fits all. We're all different, and different things work for each one of us based on that time and that place and that situation.
So I go back to the siloing aspect. One of the reasons that I started or co-founded community assistance teams of Flagstaff, the CATS bus, if you don't know, was that Daryl Marks, who is an Indigenous advocate here in Flagstaff, and I had been talking about responses to people who are unsheltered, particularly to our unsheltered Indigenous relatives in Flagstaff. And one of the things, and we're going to play off each other here, but one of the things that we see as being problematic is a criminal justice response to oftentimes what is a social issue or behavioral health or mental health issue. And of course, I agree with Corey, if there is danger, then people need to be, dangerous people need to be dealt with. But so many people who are unsheltered are not dangerous. They're just poor, they're just in need. So one of the things, the reason we started community assistance teams is that we felt that there are insufficient resources available to Indigenous people in Flagstaff, and a lot of, and even though there may be plenty of resources, a lot of Native Americans are not comfortable accessing those resources because of historical trauma and because of their own personal experiences in the community. What we wanted to do is create a more a service where we could meet people where they are on the street instead of expecting people to come to us. So we created the system looking at what are some of the holes. What are some of the holes in our safety net, the fabric of the safety net? How can we fill those holes? And one was walking out, meeting people where they are. One is getting in front of the desk instead of being behind the desk. And this is something I actually also teach to criminal justice defense attorneys. Don't sit behind the desk. Don't get in front of the desk. Meet people. Don't sit there. Don't create a barrier between yourself and the person you're serving. Sit there next to them. Treat them like a human being. Be sitting next to them, right? And so what we've tried to do is be really collaborative, and we want everyone here to reach out to us if we don't reach out to you, because we do want to collaborate. We want to know what the resources are out there, and we want to be able to take to send people in the right direction. I was able to actually help a woman who hadn't gotten a new pair of glasses for 9 years. I was able to send her to America's Best Eyewear, where they have a very small free eyeglass program. And she got a pair of glasses within a day after asking for assistance. and those kinds of things. These resources, there are way more resources than we know are out there, and we're trying to help be collaborative and bring those resources to people's attention.
Yeah, so at NACA, the concept of relatives, the concept of being a good relative, that's just that. And since taking the office of, position of CEO, that's the main one of the goals I want to, attain and accomplish is really collaborating with different organizations here in town. Just yesterday, we were able to meet with Hope Behavioral Health and substance abuse programs. Sorry, I know there are two different entities there, but with the individual, his name is Brian. And we talked about how we can support one another in a sense where, we're serving the same population demographics as well. So taking a look at commonalities there. So I asked for a list of partnerships that we have from one of our directors, and I got a big old list here. And I was really impressed with it. One of the things that stuck out in my mind with these partnerships is the Public Health Disparities Grant. Dave gave us track phones to pass out to our unsheltered relatives. That way they can access services. And, and we have a lot of relatives, unsheltered relatives that seek services in their behavioral health. And some of these relatives do have dual diagnosis with substance abuse issues going on as well. So we're thinking about how we can engage them, how they can participate in treatment. Sometimes there's a technology problem, there's environmental concerns. How are we addressing those issues? So we had the county come in. They donated track phones, and each individual, if they qualify, they do get a track phone. And these individuals can have access to technology where they can apply for jobs. They can attend their appointments either by Zoom or by telehealth. So there's a lot of really good things happening here with the county. Just naming off a couple of them too. We have partnerships with the Navajo Nation. We have our mammogram bus that comes once every 3 months as well. So yeah, I could probably go through the list and probably take a half an hour talking about some of these partnerships that we have, but it is essential. And I'll tell you this, NACA can't do it ourselves. We can't do it ourselves. And I don't see any organizations out there that'll do it themselves either. So it's really imperative that we come together and work and network and talk, have these dialogue, have these conversations about how we can develop services for people that are in need.
Thank you. And Kelly.
Just one more point I forgot to say. When you had asked about the impacts we're seeing today. And when you're looking at jail populations of 50% to 60% of our jail population being Native American at a given time, when only 10% of our resident population is Native American. When you're talking about hospital statistics, FMCER statistics, where we're talking about the numbers of Native Americans experiencing substance use disorder issues and going to the ER in comparison to 10% when it's 50% of the population, there's a disproportionate impact that's been caused by some things. It's not because of the humans or there's that much difference about the humans. It's related to some kind of historical issue or traumatic issue or trauma. And so the question is, how are we going to help, alleviate this in our communities? How can we take the greatest strengths from our different cultures and biases and strengths, right? How can we do this and incorporate this with each other without disrespecting each other's cultures and valuing each other's nature?
I, being, pretty new into Flagstaff, was also very interested in this question. So things that we're doing, at the Guidance Center, specifically, in the units that I oversee, we have North Country come in and they do Hep C and HIV testing once a month. No matter what, people can opt in and they can opt out, but that's being done every month. We have a victim witness come in and just let them know, have a group, a conversation about services provided and how they can access those things. I really believe when it comes to this subject, that we're only, you're only as strong as like your weakest person, right? So however hard you want to work for that, like you'll find it. Oxford, we all know Oxford, right? Someone that we use here a lot, but also they have Oxford all the way in Tennessee. Because I've connected members from here to Tennessee so that they can start a new life that way. And so it's not just here. And I think that, that siloed effect that we get becomes just Flagstaff, right? And we have outlining communities. I know for us, it is a huge passion just from where I grew up, and how that state is comprised, that I don't necessarily like to send my Native American members down to Phoenix. I don't think that it's culturally responsible to send them away from everything and put them in a place where maybe they can't get back, right? And so we're reaching out. We're doing things like family therapy to get the family base stronger so that everyone understands what's going on. It really just starts with questions, right? These housing has been kind of a big thing with the panel. These conversations are happening. Housing as healthcare is a meeting that I do once a week, once every 2 weeks, I think, for just members who are in crisis, who need housing, and what are we doing to take them to the next step? What services are we providing? How can we link them to those services? So there's a lot of really great things here, guys. So thank you. I'm going to take a lot back. But Cell One does track phones. Our county does a lot. I send every single person who discharges from our unit with a Narcan kit. They get a Narcan kit, they get condoms, right? So they can have like safe sex, like those things. Everyone gets that. They also, I don't know if anybody here knows, but they also just started this really cool lockbox for their medications, because it's the biggest thing that happens at the shelters right now is that, they like beat each other up and like take you their meds, and then they're off their meds and they have to come and they have to get stabilized. They have lock boxes now. So, we have the community and we give those out for people who have controls, because those are highly, sought after meds, and it makes them a target for wherever they go. So yeah, thanks.
I think we could talk so for so long, but I want to be mindful of our time and just kind of also listening to all of you talk and really think about who are the collaborators, who are the people that we turn to. I think everybody can't always go to Corey and have Corey fix everything. But so who's Corey's network? Who does Corey reach out to when, a tribal member is in need of, food or housing? Those are, I think, the areas that I really kind of want us to think about. And we're going to snatch Christopher's list at the end of the conversation. But I think those are the things that we need, because again, kind of coming back to culture, we're really kind of, talking about, our Indigenous population is culture. Our Two-Spirit LGBTQ population is a culture. Our substance use population is a culture. I mean, so we're so many cultures within cultures, and thinking about, how are we culturally responsive? What is our cultural approach to a different individual, whether they're a veteran or, they're a young person? How do we reach out to these folks and help them in some of these crisis type situations or in an intervention? What does that look like? And really, I think what we're talking about is building trust, right? Our community has to trust us. I've been doing my work for almost 10 years. And half of that time has taken me to build trust with some of our tribal communities. And so I value those relationships, and I work really hard to honor them, acknowledge them, and keep them in good standing. And that takes persistence, it takes commitment, it takes consistency. And if that's what we're doing as providers, as public servants of communities, How are we practicing all of these things to really build trust? Because I'll tell you, quite frankly, a lot of our tribal members do not trust the healthcare system. And that's because of sterilization. That's because of genocide, colonization, discrimination, stigma. All of those things still exist. And I think it's really more about truth and reconciliation. We need to acknowledge these things, but also understand that, some of these things happened, times back, but how do we move forward? Yes, we acknowledge, let's reconcile and move forward. But if people are still having those bad experiences, whether it's in the ED, whether it's in the jail, or whether when they get pulled over, because someone doesn't able to practice that cultural humility, that then kind of taints the whole reputation of our community, of Flagstaff, of Kingman, of Page, of wherever it is that we are in this region. And those resources, how do we incorporate some of those culturally responsive approaches into drug court or into diversion court system? How are we addressing that in the delivery of when a police officer stops somebody on the side of the road? How do we address that when somebody picks up the phone from Solari to help somebody with a mental health crisis? It's really about education. I'm really excited to see some of our providers do have tribal liaisons within them, or tribal case managers, tribal caseworkers to help them, but I don't see it enough. I don't see the tribal members, the tribal leaders at the table. And that's really what we need to have these conversations about. We're talking about communities, but where's the community? How are we finding out what they need? What's going to be helpful to them? What was their experiences, and how can we help rectify those situations to gain that trust? Because we all know the stigma is still there. We know the discrimination is still there. We know the resistance, the frustration, and we're just all frustrated. I lost my father to alcoholism, and I wished I would have known a lot more about what I know today, to help not only my family, but the community, because I see it every single day. I see middle school children in our communities dying from opioid overdoses. It's this revolving cycle of ED, jail, community, ED, jail, community. What are we doing to be more culturally responsive, practice cultural humility, regardless of what culture it is? I stand up here representing the indigenous community. We know we have 17 tribes in Northern Arizona, but we probably have about tribes from people living here from about 400 different tribal communities outside of Arizona. We can't be centric in the way that we think. And I think that a lot of times it's easier to do that. So how do we customize and tailor our approaches? How do we leverage the champions in our communities? How do we leverage the champions within our organizations? We have some up here at the front, but I really hope to see that we are able to be more culturally responsive in our approaches, and that we can begin to really practice that cultural humility organizations, and it starts at the board of directors. Us is, I believe, truly somebody who allows that work to happen and can be flexible and adaptable to what that means, because they understand it's not going to be the same way for every single tribe I work with, or every single tribal member. Sometimes I'm traveling here and there to get somebody, a family member, to their child down in Phoenix. I'm making sure siblings are connected because they haven't spoken with one another. Sometimes I've had people show up to my office with a child that has no place to go. And so how do we fix these problems, or how do we address them together in that collaborative way? Your monthly meeting, your bi-monthly meeting, how come we don't know about that? How come I didn't know about that? You know, these are the things that I'm hoping we can really hone in on and gather. So hopefully you guys have already exchanged contact information. But my last question here is person-centered care. What does that mean? People first, or people first. I'm a mother, I'm a sister, I'm a grandmother, I'm an auntie, I'm a friend. I might have a really bad day. You know, I have had my bouts with depression, and that doesn't mean that defines who I am. And I think that that's something we sometimes forget, even in the way we talk, you know, about schizophrenic people or about homeless people or unsheltered people. I teach my kids every day. My daughter got nervous because a gentleman came up asking for some bus fare. And I got after, I scolded her. I said, you know what? That's somebody's dad. That's somebody's brother. That's somebody's son. You talk to him like he's a human being. And she didn't know what to say, because I've had those experiences. I know that my father's been out on the street too, and hopefully somebody wasn't mean to him, because he's also a dad, a grandpa, an uncle. So person-centered care. How does your organization implement person-centered care in the delivery of its services? My question.
Okay, I'll go first. So this is a huge thing. This is actually the basis of the therapy and programming that I center the program around, right, is being person-centered, right? People drive what this looks like. We really are working on a change of perspective, right? And I have people in my program anywhere from 28 days to 90 days. And so I'm not going to get a whole 180 perspective change in that time. But if I can do this and they can come around just a little bit to really understanding, it puts them on the correct path, right? Because a lot of times coming into, it doesn't matter what we call it, right? Everyone's like, oh, I'm in rehab. And that in itself is really just like gut wrenching and demoralizing, and they've somehow failed. And so really getting from like, your addiction doesn't define what you are. Your choices don't define what you are. Your choices while addicted don't define you. You're more than that. And we need to come to a place where that and it's okay. And to tell my members is, why is it worse for you to have done any of the things that you do, and yet we glorify celebrities who have all of their own addictions or who have done all of these crazy things, and yet they still make millions of dollars, right? And you went to court, you served your time, and like, it's all done now, right? So why is that okay, and you're not giving yourself that grace? And so it's really that change of perspective and just embracing, your new person. We're growing. So yeah.
Thank you.
I'm going to steal this one. So person-centered care to me is listening to people and letting them drive whatever it is that they want out of life. And it's taken me a long while to get there. I've learned from a lot of people about this. When I was a new lawyer, sort of back in 1990, I was asked by the elders at Hopi Village of First Mesa to document traditional law. And I represented the elders as well. And I would go to the reservation up to Hopi over at First Mesa, and I'd be wanting to go, why can't we just do this? Why can't we move forward on this? And it took a while for me to step back and say, that's my Western culture getting in the way of me listening. And it took me a while to listen and say, I need to follow the lead. I can't help you. I can't direct people on how to do things. And it's the same is true with individuals. I had a very good friend who I met here in Flagstaff who was unsheltered, or I met him after he was unsheltered, but we became very good friends. And I worked with him. I struggled with him. I felt for him. I cared about him. I tried to do my best to support him in every way I could. He tried rehab. He'd been through rehab. He'd done it more than once. He'd been in prison. He'd experienced all of these things. One day I saw him on the street and I knew he was feeling badly. He didn't have a sleeping bag. I went and got him one and I brought it to him. And I asked him very carefully, I said, so have you thought about rehab? And he kind of paused and he was kind of like he was just kind of not responding. And I go, is it just maybe too overwhelming? And he just looked at me and he said, yeah, I'm so glad you understand me, Auntie. And unfortunately, the next day I saw him also, and I gave him a backpack. And unfortunately, that night he died on the streets. And I was the first person that was called by police because I was his emergency contact. And he taught me a lot, because what he taught me was, can you just accept me for who I am? And that's what person-centered care is, I think, is accepting people for who they are, wherever their limitations are, if you even want to call them limitations, but where they are in life, wherever they are, don't push, don't force, don't try to solve their problems. And I'm bad at that. I'm a lawyer. I've always tried to solve problems, but to try to accept people for who they are and let them lead that kind of their own life path. That's what I think person-centered care is.
We have about 5 minutes left.
I'll be really quick. One of the most beautiful things is for an individual, an Indigenous person, to introduce himself with their clan. And Holly just demonstrated that when we got started. I was like, wow, that is power. That is identity. That's what it's all about there. I mean, we think about, historical trauma, and I'll be real. I'll have real conversations about this. It wasn't no more than 40 years ago that the Freedom of Religion Act came, where we could practice our own religion. It wasn't too long ago where we were entitled, for granted full citizenship of the United States. What does that do to an individual? On a personal basis, I come here, there's a certain fear I have sitting here and looking at people other than my color. That is genuine fear. How are we addressing that? Right? So as a psychotherapist, as a person, as a clinician, down empowerment value is addressing that person first. Where are you from? What are your clans? What village are you from? Right? Not necessarily going into, oh, you know what? I see that your PHQ-9 indicates that you're a severely depressed person. Can we talk about that? No, that comes, 7, 8 sessions later on, probably. So that therapeutic relationship is built on trust, and the idea of safe space, that's a real thing. How are we facilitating that? So I'm gonna give these guys a chance to answer that. So that's what I would have to add.
Yes, what they all said. Yeah, I can't agree more. Most often I get called, and it's about fear. so much is about fear from everybody. Everybody's afraid. From meeting with Aaron, you've heard in most of my answers, I take individuality every single answer I've given answers on how I look at them first. That is the core of how I view people. And so I look at their situation first, then I go to the broadest perspective, and then I go back to the middle perspective. And that's just kind of how I keep people centric to the work that I do or we're at. But she had said something in the meeting about what is my network or who do I call? Well, heck, at every table, I see people pretty much that I've called and asked for help from. You know, you get Tatum right here. I've talked to her. I talked to Bree. I talked to Dr. Khan. I talked to Summer. I talked to everybody all over the place. Dr. Roddy's, oh, she moved. Yes. I mean, I just call and I ask for help all the time. And so many people help me. So when we talk about who you go to or whatever, it's all of us. You know, we all give a small piece, and we just work as each other's kind of network to get there for that person who's in front of us on that day and time. But none of the knowledge is mine. It's all a collective thing that I share.
Absolutely. Be quick, I promise. I think that with reducing stigma and person-centric care, that really it is about treating the individual, and that like understanding that treatment is so specific to each human, and like having that conversation one-on-one of just being a human together is so impactful, like what Wendy was saying earlier. And that all of our systems, all of us at this table, all of us in this room, our systems are inherently harmful to our people. And that's the unfortunate reality of systems. And so even though they're built to support and we try really hard to make them work, that's not always the impact. And so for us as individuals to be that human face within the cog of the hospital, and figuring out like, how do we identify one-on-one with this person to know that there is someone who cares about them? Like, yeah, I'm your social worker, or yeah, I'm your program manager, or whatever it may be, but like, I care about you as an individual. And so how do we work through this together is such an impactful thing that maybe that person's not ready for rehab at that time, or maybe that person's not ready to take that next step right then. And that's fine. We'll be here whenever you're ready. And so having that base understanding and that compassion and that patience, I think is really paramount to providing people the support for when they are ready to accept that help, or maybe they're ready to try, that they know that they'll have someone that they can rely on even within all of our systems.
Excellent. Great. Thank you so much for your responses. And I think we have 1 minute left. So I'm going to try and put a bow on this. And hopefully this conversation doesn't end here, and that we're able to continue conversations and really strengthen relationships and collaborations. But you know, having this conversation, and we really didn't even get to talk a whole lot about social determinants of health, but that is in everything, you know, whether we're talking justice or we're talking healthcare, housing, you know, all of those things. But when we look at it from a tribal perspective, you know, what does that look like? What is, you know, social determinants of health from a tribal perspective look like? You know, what does that health equity look like? Health equity looks different from person to person, from region to region, community to community. So I think we really have to remind ourselves that we're similar, but we're also very unique, and that's a beautiful thing. One of the things I also wanted to just really kind of share with the group is, you know, taking the opportunity to bring in some tribal competency activity training. I offer myself, I do that training. It's just, I think, something that kind of helps have those conversations, have somebody come in from the outside and really kind of work on having those difficult conversations, because it is a bit challenging to talk about a lot of those things that we talk about, federal policy and the impact of policy, and that still has an impact on our tribal communities today, which still there impacts tribal members and how they engage in the Western society and in their offices and in their grocery stores. There is an impact. Really understanding the listening piece, and I appreciate that. You know, we want to tell a story. We have a story to tell, and the sense of time is different how we look at time, how we honor time, even what we say a lot of times is very intentional. But I think at the end of the day is always remembering that there's a variation in everything. We have some really true traditionalists. I don't believe that there's a really traditionalist. We still a lot of times either get in a truck. We might live primitively, but we might still have a truck. We still have to go to the grocery store sometimes. You know, our crops don't always grow well. So, but variation in everything. You know, we have our urban Indians. We have people who practice different religious denominations within tribal communities. So to think that when we're talking about this particular population as all a general conversation is not going to be beneficial or have great outcomes. Really understanding that one-on-one service, what does that look like? The literacy part of it, you know, how are we messaging? How are we communicating? You know, what is our language like when we're engaging with one another, whether it's your colleagues or whether it's your community or your families. Trust is really what we're after at the end of the day, not just with this particular population, but with our entire community. And so I think that, you know, I leave you with that when we thinking about culture. Yes, we talked a lot about tribal communities today and tribal members, but there are many, many cultures that we serve. And a lot of them are going to have very similar experiences, which make them a culture. And how we engage, how we approach them is going to determine the outcome of our engagement, whether it's for 5 minutes or whether it's for 5 years. So I thank you for your time this evening. I don't know if anyone has any questions or we have time for questions, but I would really encourage us to all engage at some point. I'll be here for a little bit after, so I think we do have a question in the back.
It's not so much a question, I just can't resist having a captive audience. My name is Sandy Keith, and I'm a dependency program coordinator at Juvenile Court. I'm going to try to talk as fast as I can. I want to, in the spirit of community collaboratives and partnerships, I want to let you know that Juvenile Court has a lot of programs that are really exciting to me. One is our Hope Receiving Center. If you haven't been by, I encourage you to come by. We have gone 10 years ago, our 4 detention pods were at the max, 35 to 40 kids. Now we have, I think, two kids in juvenile detention right now. And so we used ARPA funds to convert one of our detention pods into this Hope Center that is a short-term resource and referral service. So we aren't, it also houses our probation diversion program, but it's also a deflection center. We're trying to encourage families that don't know what to do. They're at the max with their parenting skills. Anyway, so come by, call me, I'll set you up and take you on a tour. The other is the Safe Healthy Infants and Thrives Safe Healthy Infants and Families Thrive program known as SHIFT. It is a prenatal substance use intervention. If you have in your work an opportunity to work with pregnant persons that you suspect are using substances, please let us know. We coordinate care and try to help them on that road to sobriety, stay sober. We can't guarantee that PCS won't be called when their baby is born, but it certainly decreases the likelihood. I also want to let you know that we are reinvigorating the Children Incarcerated Parents Program. If you are interested in that, all the way, we're working on some of the recommendations that were put forward 10 years ago, 10 plus. And so we're looking at how law enforcement officers respond when children are present, training them to take those things into consideration, and all the way up to how do we help children and family members maintain their family connections through while they're incarcerated. So if that sparks any kind of anything, I would be glad to give you my card and do that. And I also one of the programs that I coordinate is the Family Treatment Court. It is a specialty court like recovery court, but we add the extra layer of caring for the family because every single one of the participants that is eligible has an open DCS while they're working on their substance use issue. So we're doing a lot of work. I'd love to talk with you more. Come by and see us. We're not just another juvie movie over there. And we're doing what we can to go upstream and help solve some issues.
Great. Thank you
Break
so
some
much.
cycles.
Thank you. I think we have another one over here. Sunshine. Sunshine.
Thank you, everyone. I appreciate all of your comments. I just wanted to add one because I'm not sure I heard it from the panelists. Maybe Holly addressed it a little bit at the end, but as far as culturally responsive services, from what I can see within my organization, is a need for representation at the very top and all the levels below. And I personally don't think that we can truly have culturally responsive services until we start to see that happen. So I think in systems anymore, and that's where I keep coming back to these days is without representation, we are just guessing. So thanks.
Thank you. Appreciate that. Okay. Anybody else?
Any other comments or questions? Folks, how about a big round of applause for Holly and her panel? That was tremendous.